About the Venganur story from Bhagat Rufus and Vijayanand sir and again Vijay Kumar sir about a survey that identified many households with abject poverty where mothers of children with developmental disorders were unable to go for a livelihood and were socially marginalized, isolated. And when I was working in Bihar for the revised National Tuberculosis Control Program, when you say that there are medicines at the state, when I ask a district TB officer to please indent for medicines, what they used to say is, likhit nahi hai. So there is one order which says that all districts have to implement the revised National TB Control Program. That's not enough. So what we consultants did was, we took the 9 modules of the TB manual and split it into about 85 government orders, which the state TB officer had to circulate to say that you need to get medicines, you need to take the microscopes, you need to train people, you need to give medicine, you need to monitor, you need to fill the TB treatment card. This likhit nahi hai is something which is used not to work. Even in Kerala, it's like that. Many things that's not on paper, it's very difficult to convince somebody to do that. And that Anand sir and others come. There's no provision to start something like this. When there's nothing like that, how do you identify a building? How do you keep money apart? How do you send somebody for training? Right, that's the true innovation. And I don't have time to go into the whole stories, but it's been documented and you can find the report there. And the numbers of bud schools mentioned here was probably we've gone much more than 20 or 100 or something. Initially, the bud schools were meant for children, but then, see, there's a reality. And that's a reality which even the institution I come from, Sri Chitra Tirunal, fails to solve. A child with autism, a person with cerebral palsy, once they reach 18, in the medical government system, they are now an adult. So the pediatric neurology cannot cater to them anymore. But in reality, the situation for the family doesn't change. They still have the child or the person with this particular disorder. So it was possible for the community to come with a solution. They started BUDS rehabilitation centers, not calling them schools. So you could have persons above the age of 18 still receiving some form of services and rehabilitation. So we have more than 140 bud schools, and the number is going to increase. So some of the presidents were telling me that they are also in the process of establishing bud schools, and we have 153 rehabilitation centers, about 10,000 registered beneficiaries with a variety of disorders. And this is again the number of projects. They may not be the same as the number of schools or institutions, because one panchayat can keep 2 projects, like one for some infrastructure, one for training, and one for food, like that. And in the last decade, much of the money has gone into expansion of the BUDS rehabilitation centers, because the BUDS school expansion happened largely before that. And, you know, we talk about the silos have been broken, no? We take the human body and fragment it into so many bits and pieces in the biomedical approach. Here, it's all of them together. You know, you have refractory epilepsy, you have intellectual disability, you have cerebral palsy. I've quoted, so some of the terminology may not be politically appropriate right now, but I've just quoted one of the trainers from exactly what she had. We can't blame the trainers also, because the degree that is given is, I think, a diploma in mental retardation or something like that. It's the official degree in our country. So how has the LGs contributed? Infrastructure, buildings, classrooms. Some of the bud schools have smart classrooms, many of them. Okay, equipment for routine furniture, office room, therapy, etc. Therapies in plural. Remuneration for the staff, trainer and helper. Transportation, a bus or a hired vehicle. And transportation, believe me, it's a huge challenge, because many time there is also the care provider with the child. And sometimes you need 5 trips. So some of the BUDS institutions were saying that the vehicle goes out at 6 in the morning, the 5th trip gets over by 11. And by 3, it's time to start the trips again. Because these are not, you can't just put all of them into a big bus and bring them here. You need to make several trips. There are wheelchairs, there are care providers who need to come. mothers who also may accompany the child to drop them at the school like that. Okay, and support in terms of food supplementation, financial aid, as well as some other things I have not listed, like documentation for the Niramaya insurance of the government of India, which is again the BUDS teachers are facilitating that. I'll just wind up by saying that the main problem that we found is heterogeneity, especially in this, because staff salaries in one BUDS, because that panchayat has able to generate more money, keep more money aside, the remunerations are different. What people call as pensions, the financial aid to the beneficiaries are different. In one panchayat, somebody gets 28,000, the next panchayat it is 15,000. So there is a lot of heterogeneity depending on what the panchayat is able to negotiate, and that's something. A lot of rehabilitation and income generation initiatives have been piloted in many of these BUD schools, but we see that that doesn't really translate into increased income for the institution or for the, so that needs to be looked into why that is happening. Usually it is lack of platform for a sale of the products that are made there. There are tailoring units, there are candle making units, there are many units that do function, but for some reason these have not translated into financial advantage in a big way. But of course, the role of the panchayat, it's really there's a lot of commitment there, and these are people who may never cast a vote. That is the basic message here. So even if there is a shortage of funds on any other project, we will not reduce the funds for this activity as it is being received by the children. And the COVID was a test for the BUDS institutions. Not a single BUDS institution has closed down. Not a single BUDS teacher said that she did not receive her salary, he or she did not receive their salary in that month. The food supplementation which was happening in the BUDS schools was given to the beneficiaries at their homes. There was no cessation to that. The state government had an app, Tenkuda app for continuing education, which was more or less a failure because what the parents said is that the child tend to throw the phone away when it's a smartphone. So, and there is a prioritization of the non-disabled child in the household because the non-disabled child has a school, regular school. So the disabled child with disability does not get the same priority. And then many families do not have a smartphone. Women are the primary caregivers, are not adept at handling smartphones. So the app for continued education during COVID was not a very successful thing. But otherwise, I can say that it's a very good indication of resilience that the BUDS institutions all continued and did not have much of a setback in the COVID pandemic. The main problem is limited trained therapists, getting trained therapists, and I do have my apologies to Jayan sir. So Jayan sir's panchayat had repeatedly asked me to get some, they have kept aside funds for speech therapist and physiotherapist. They were not able to get even after advertising twice. So I went around asking all the rehabilitation institutions, but many of the professionals, they are not really interested. We are not interested in working with the local governments because they cannot give us a proper employment letter. It's like 2 days a week they are expecting our support. And professionals want experience. They want continuous, guaranteed remuneration like that. And some of the professionals who have gone there said that the funding from the panchayat is irregular. So people want 9-to-5 jobs and monthly paychecks. And LSGs may not be able to offer that. So probably at the secondary level or at NHM, if we could find some ways where we could have a pool of rehabilitation professionals. So these are some of the ideas that we had at the end of the so I'll just wind up with this. One of the trainers said, I was just a teacher when I got appointed here. I didn't know how much about anything, but got full support from the panchayat. Whenever I call them for anything, they will come and help us. If the BUDS is a success, it is mainly due to the panchayat's performance. At times, they have helped us by buying rice for cooking. Whenever we call, however busy they are, they always make sure that we have provisions. I cannot describe the support I've received in words. I'll just wind up with the last point. We have another 2 minutes, I hope. So the story of Venganur you heard. This was in 2004. And I'll go to the story of Mattanur. So in Venganur, the story was one of abject poverty, societal neglect, and stigma. These families were not invited for marriages or such things. And in Matanur, in the recently concluded Republic Day parade of the district, the band that performed was the band from Palshiraja Memorial Bud School. And also, the school also has a school dance team which has got accolades from across the state. So, what is it about disability? What is about marginalized people? They need to be seen. So, from a situation where they were, so I'll just go back one slide. A pilot that was initiated at one end of the state within 2 decades, even after the COVID pandemic, and all the changes that have happened in the state, these people are now visible. Okay, they are part of society. Okay, they are dignity, they have a dignity. So that is what I'd like to conclude. So again, I mentioned about models of compassionate governance that we see. The decentralized space has helped initiation and expansion of projects based on community needs. Many things which started as kind of a de facto mode became regularized and spread across the whole state. And this is not to say that the state did not give inputs. The state, the modification of the fiscal structures, augmentation wherever that was needed, and bringing in guidelines to bring in some, because audit objections could be a problem. And then the state gives a order, and then panchayats can freely go ahead and continue service provision. But of course, like all decentralized examples, there's market variations from place to place that remains a problem. And for both the buds and the palliative care, I think we should think of having robust information systems that help us learn what is really happening, identify gaps, and guide further improvement. Now, I don't want to take, none of us at HAP or want to steal the thunder from what all this story, it's their story. It's a story, we have some of the representatives here. This is a story of people and their representatives. And we thank them, first of all, for helping me and some of my students to listen to their journeys and learn from them. And I also place my thanks to the wider research team at HAP and all the collaborating institutions, as well as Health Systems Transformation Platform, for giving us this opportunity to learn and make this journey. Thank you.
So we have got 4 minutes left. How much? How much?
Depending on the questions, and I think we can take a little time to have a discussion.
Okay, now you can raise your questions. What she's saying is we can have a few more minutes, so we can discuss depending on the type of questions that comes in. Over to you. Don't waste time. Yes, sir. Boliye, sir.
Nobody is coming up, so I thought, thank you for a wonderful presentation. You said the people on this side of, I'm Tarun Seem. May I ask my question? I just have 2 minutes. So you said the people on one side of the road, which is managed by the Panchayati group, is able to get the services. People on the other side, managed by the corporation or the urban part, doesn't get. What do you conjecture is the difference? Why are they not able to do it on the other side of the road?
Yeah. To be frank, I don't have a complete answer to that. But as we were saying yesterday, this is something that is reflecting across all the programs, not just palliative care. Our experience is this, that if there is a stroke patient on the panchayat side, the stroke patient kind of gets 7 or 10 medicines and a monthly visit by the palliative care nurse. Whereas, and if there is a, the person is catheterized, the nurse comes every 3 weeks or 4 weeks to change the catheter promptly. But on the corporation side, probably because the population covered is larger and the kind of monitoring and evaluation mechanisms are not the same. the visits are less frequent, the number of medicines received are lesser. And in urban, it's again my impression. I may be wrong, or I think this may need to be validated. We have, it's not just duality. We have the corporation with their priorities. We have the national, ultimately, who's really looking at the palliative care project. It's, so I don't know how the monitoring mechanism happens there. The other thing is the guideline clearly says that for 30,000 population, you can have one palliative care unit. But I find the number of palliative care units in the corporations are far less than the population that they cover. So that could be another reason.
Just, I am Mohan from KHPT. I want to understand the number in the palliative care, because Kerala also have a huge in the palliative care, because Kerala also have a huge migration for outside the country as well as internally. What is the number who is actually staying alone, like the parents and people are, especially children are staying outside? Do you have any kind of at least some percentage of people? Because the demand is very high, they are not living with the joint family, such cases.
I may not have the exact demographic at the population level. Based on the data that we have collected, it's living alone, especially for those above 60 years, it's somewhere around 10% in the micro level surveys that we have conducted recently. And the living arrangements are a bit complex sometimes. You have, like just recently what one community I went to, there's a woman, she's living alone in that house, but then she has food at the next house and she takes her bath in another house. So, and they are her siblings. So we were having some difficulty in really defining this living alone thing. If you ask her, she'll say, I'm living all alone. My child is married somewhere else, like that. So about 10% are really living alone, but then there are others where it's there's a child who visits on weekends, or there's a sibling next door, like that. Yeah. Yes, sir.
Not actually related to the presentation, but more generic. I hope, can I raise, sir? Dr. Vijay? Yes, thank you. I think my name is Sunil, My name is Sunil Nandraj. I'm an advisor at HSTP on health system governance. I think from yesterday we have been hearing about decentralization. It's quite, the way it was put, it was like kind of a romantic, highly romanticized, and we heard a lot of Kerala. In fact, a lot of experiences, great work, fantastic, but Kerala is not India. Please, let's get that into our thing. I'd just like to raise some issues in the context of decentralization. One is, I think decentralization is about power structures. There was something touched upon. How is anybody going to give up power? That is going to be the critical issue. And here I am talking about, and the focus was mainly on local governments, panchayats, what great work and all fantastic, very good. But here we are now in the debate of whether health should be a state subject or go into the central subject or in the concurrent list, which again is an issue of decentralization. And we saw what happened in COVID, the highly centralized nature of control, where ICMR wanted all the tests to be put in that place. Kerala did well, Maharashtra did well, great. But look at the way the centralization is taking place in our country. I don't want to name names because forget it. The highly centralized nature, everything is into one office. You cannot move a file without that particular office. I think we'll have to really reconsider. Well, there is a beautiful state called Kerala with its coconuts, but there is the other India where high centralization is taking place. I just like to raise this entire health as a state subject. In fact, Tarun, I hope it touches upon, we have been writing a paper for the last 6 months and we have not finished it, called Health as a State Subject. The British were really not interested in health. They just gave it away to the provinces. I think Tarun will share. Because something different, whereas the cantonments they controlled. Another area I think is the bureaucratization of how bureaucracy and decentralization work. In Kerala, you had a benevolent bureaucracy, but does that happen in other states? You know, you had very good bureaucrats who wanted. Look at your own decentralization that is taking place within your health department. The health department does not, we have killed our directorates of health services in most of the states, which were one of the most technical units, and we are talking about decentralization. Look at the directorate has no value now. It is the department, even in Nirman Mohan ministry. DGHS has no decentralization.
Sir, can you actually come down to your question?
No question, I'm just raising issues. Sir.
Okay, fine. We are hard pressed for
Just
time.
1 minute, let me finish. I'm just raising. I think one of the things is also panchayats and the caste factor. I think we would like to look at what is the caste factor, how does caste play? Because we are hearing more and more cases of caste panchayats not allowing the lower caste even to take out water or go into the temples. And I think this needs to be looked at. How does decentralization, not many people have touched upon the privatization of healthcare. Highly privatized healthcare is Kerala. Look at your expenditure, out-of-pocket expenditure, very high. Your utilization, not many people are going to your primary health center, sir. It is highly privatized. Please, your expenditure is one of the highest in India. Out-of-pocket expenditure, your utilization. Contracting of health services under NHM. Yeah, Rajiv, I saw your hand. Okay. Is it only service delivery or policy making also in decentralization? I think these are some of the issues of concern. Thank you.
Thank you, sir. Actually bringing out those issues. Nobody has actually said that this is something like a heaven. There are issues. Even almost all the studies, right from yesterday and our presentation itself was saying it's a mixed bag and it contains positive and negative things. We have come a long way. There are so many challenges that we have to address. All those things cannot be addressed in this forum here. It requires a lot of time. Because for want of time, I'm sorry, want of time, we are actually stopping. Whoever actually raise questions, please write it down and maybe personally we can very well discuss about that. I'm sorry for want of time. Okay, fine. So thank you for your patient listening. And I'm sure that there will be enough time for all of us to discuss as Sri Sunil Nandaraj was doing. You can raise questions, you can put your views and all those things. Actually, the organizers have reserved some time towards the post-lunch session. So please reserve your questions and suggestions. We want everybody to actually share your views on this particular topic. It's most welcome, but not at this point. I'm sorry.
Thank you very much, Dr. Vijay Kumar. Yes, I've been told also by Mr. Sadanandan, the last session today, we will have ample opportunity for all these sort of issues to be put forward. You're most welcome to share your views, your concerns, and any other things that you want flagged for their attention. So feel free to do so in the last session. I'd like to request Mr. Srikanth Vishwanathan now to please come up and present mementos to Dr. Ravi Prasad Verma and Dr. Vijay Kumar. Ladies and gentlemen, I'd like you to give a really rousing applause for Dr. Ravi Prasad Verma. I think the stories that he's shared with us today, these are stories of courage, these are stories of commitment, and they really need to be applauded. The Kerala model is not the ideal model, but it is a model that we would like emulated across the country. And it is a model where you've got these stories that come up in sessions like this, which otherwise we would not know of. So these are struggles on the ground. These are struggles that need to be highlighted, need to be shared, and lessons learned from them. Thank you very much, Dr. Prasad and Mr. Vijay Kumar, for chairing this session. We're moving on to the next session now and make the changes on the days. If you could have the chairs added and the names to be added here. We're moving on to the next session quickly. If I could request our speakers to please join us on stage now, and Dr. Sasi Kumar. Our chair for this session, Ms. Urvashi Prasad, Director in the Office of Vice Chairman Niti Aayog, will join us very soon. She's got some urgent work that she has to complete. Please come up. I don't know how to make space for you, but if you could come up from here. So we will have two presentations first that we will share with you, and then we'll have the panel discussion. Health and fundraising, and is responsible for expanding its work and driving project delivery and engagement with government stakeholders and donors. He brings a diverse experience spread across a period of almost 3 decades, adept at leading business development, fundraising, strategy, planning, business operations, and forging strategic alliances in the healthcare sector. Mr. Guha will tell us more about the decentralization journey in Bhubaneswar and Bihar, and I'll introduce the other speakers as they come up. Mr. Guha.
Okay, great. Yeah. Thanks, Rini. Good morning, everyone. Before I start, this presentation is going to talk about what we learned when we looked at Bhubaneswar as a city, as well as our work which we did in Bihar. Interestingly, although my colleague talked about, Asa talked about our findings of these 3 large cities, uh, as a sense we got was that Bhubaneswar was more aligned to the majority part of our country. I mean, of course, you had cities like Bangalore, Chennai, and Pimpri Chinchwad, with really which have taken leadership positions in leading primary or managing primary healthcare. However, those models, as it's pointed out in the report, are only about 10 cities which are actually managing primary healthcare. So therefore, we looked at Bhubaneswar specifically because, as I said, the alignment with the rest of the country was far greater. And therefore, we felt that it's only pertinent to sort of highlight what has gone on in Bhubaneswar over the last few years. And also as a comparative, sort of effort, we looked at 9 cities in Bihar. Just a quick background on urbanization. We all know we're a country which is rapidly urbanizing. And as I said, there were similarities between Bihar and Bhubaneswar and Odisha in general, because in terms of the urbanization, in terms of the extent of urbanization which has taken place. Although with recent trends within Odisha and specifically Bhubaneswar, there has been a strong improvement in governance, specifically with works done in ULBs. Talks about the demographics of Bhubaneswar. It's about 11 million people, which is now up to almost about 12.5 million people. The city has 3 zones. It's divided into 3 zones. The corporation, about 67 wards, 170 PHCs, and some secondary care institutions as well. Interestingly, in 2014, the USAID's health project, Health Urban Poor project, which this undertook for the first time extensive slum mapping. Um, Post that, the government has embarked on something called the Jaga mission in 2017, which empowers slums and transform them into inhabitable or areas which have specific infrastructure as well as services which are aimed at the slums. And whilst the USAID project in 2014 took up the urban poor project, it was also, I mean, the municipal corporation is one of the few which also looks at non-notified slums as a focus area. So even after the project of USAID, it was actually a decision by the ULB to look at the so-called the have-nots, or the people who are possibly under, let's say, flyovers, or those who are non-notified. Um, it also has a very vibrant presence of Mahila Arogya Samitis. This slide talks about an operation model which the ULB has devised. Interestingly, if you see, there is a specific department of health in general, but it has two components to it: a public health department and a medical services department. And this is there is a very senior resources from the health department which have been deputed as part of the urban local body, who actually oversee the entire gamut of public health operations. One of the officers, presentation, something wrong. One of the officers looks at public health functions, and the other officer looks at the NUHM and state-specific grants. These two senior officers, I mean, what happened in Bhubaneswar was the existing urban institutions, maybe dispensaries, maternal child centers. These were some of the facilities which were upgraded into urban primary health centers through the NUHM once the NUHM came into existence. Currently, there are about 7 or 8 services which are rendered as part of their entire gamut of comprehensive primary healthcare services, with emphasis on geriatric or NCD functions slowly creeping into the operations of the entire public health delivery. The pharmacy and consumables are centrally procured at the state level and then sort of supplied to the ULB. Interestingly, the specialist clinics are on a roster basis, with the specialists provided at these primary health centers by private practitioners who have been brought on board on an honorarium basis. Now, this is extensively communicated to the citizens using social media. I mean, the extent of social media which is which the ULB uses is phenomenal. During the entire period of COVID, and we saw active use of what is this roster of specialist clinicians which are being present in the various UPHCs on a roster basis. The entire planning, the resource is done based on resource pooling of NUHM, state, and other central government grants. The planning, budgeting, drawdown, disbursement, utilization is all handled at the ULB level at a comprehensive basis. Some of the key takeaways from the Bhubaneswar model, so to say, and it's been pointed out in greater depth in our report. There's been a clear mandate by the state governments to empower ULBs in public health. Strong convergence between the municipal corporation and health department, which is the bedrock of any successful or effective public health delivery. The existing infrastructure, as I pointed out, has been upgraded to UPHCs with the support of NUHM. Vibrant use of social media, specialist clinics which are operated on a rotational basis, And one thing which was very stark in our when we sort of did these field visits and engaged with political representatives of the ULB themselves, the councillors were extremely involved in the day-to-day operations or even day-to-day operations or a comprehensive operation at the ward level. I mean, we visited, I think, some 3 or 4 UPHCs, Navdeep, if I remember correctly, but there was an extensive involvement in not just planning as to what kind of services are being rendered, what is the focus area of that PHC at a ward level, as well as the community outreach services involving the Mahila Arogya Samitis. Um, to contrast that with Bihar, it's about 12 million population, with about 12% currently in urban cities and towns, with a lot of concentration in Patna being the largest urban agglomeration area. There are almost 44% of the urban population resides in Nagar Nigams, and there are about 259 ULBs across the state, 18 municipal corporations, and the rest are distributed between Nagar Panchayats and about Nagar Parishads. Currently, out of about 105 UPHCs which are present in the about 41 towns and cities, not all of the ULBs are covered with urban primary health centers, but since the advent of NUHM, there are 41 towns which have been covered by UPHCs. Interestingly, what we found out was in 124 clinicians, medical officers which were in these UPHCs, out of them 98 are in deputation and 26 are NUHM. So there is a huge shortage of human resources and full-time medical officers who are dedicated for these UPHCs. About 82 of these 105 UPHCs are in private buildings, which is rented accommodations. In our study, as I said, we looked at 9 cities in Bihar. How we sort of selected them were, Bihar is divided into 5 administrative regions. 5 districts out of these regions were selected, and based on criteria which involved sort of output indicators from NFHS as well as urbanization, we picked out Patna, Gaya, Purnia, Bhagalpur, and Sivan. As part of our study, and this has been brought out extensively, and you'll sort of be able to go through that in the report, what we did, and I think Shrikant pointed this out, we studied about 22 municipal acts. The findings of our desk research, although we've mentioned it as part of Bihar, but because the concentration was Bihar and other states, what we've tried to highlight is what did we observe through our desk research. Largely, ULBs are empowered in their municipal acts to handle primary healthcare. However, it's a more nuanced than that. Community health, although is a core functions, as part of the core functions, however, the preventive, promotive aspects of primary health is relegated or classified as additional or other functions. And that's where the nuance comes in, because most of the interpretations of public health in the municipal acts is limited to the traditional handling which the ULBs have by virtue of just practices been able to sort of, just focus on, namely solid waste management, wash. The State Finance Commission reports, which we looked at from a policy perspective, have recommended increasing expenditure on primary healthcare. But specifically with the 6th State Finance Commission, although they have mandated 40% of the development fund to ULBs, which should be untied. However, what's happening is on ground that the actual utilization of these resources is where the gap exists. In the ULB Acts, the health officer does find mention, but the role is varied. In Bihar, it's just limited to registration of births and deaths, vital statistics, and control of prevention of infectious disease, namely vector-borne disease. And obviously, these are some of the traditional areas which the ULBs, are handling. some of the key takeaways of our field visit in Bihar. I just pointed out huge challenge in availability of full-time dedicated resources in urban primary healthcare centers. And that's one of the things I guess the state will have to look into, specifically with 15 Finance Commission's provisions, sort of earmarking or allocating funds below the UPHC level, which is akin to the sub-health center at the rural areas, the health and wellness centers, which will be at a 15 to 20,000 population. The challenge, I guess, which they'll be facing is how do you get in more human resources? Because the current infrastructure system is already hugely challenged with human resources. NUHM funding has improved infrastructure most definitely, and also the availability of drugs, but we did see instances of, sort of shortages of drugs and consumables. Patients of more than 30 years of age coming to the UPHCs for any ailment or screen checkup are screened on NCD guidelines. Service deliveries of areas have improved. However, the coverage of that needs to be definitely worked upon. Interestingly, there are specialized immunization corners in UPHC, so that was a feature which we saw in a lot of urban health institutions. And many of these UPHCs are conducting yoga sessions on alternate days. And the Jan Arogya Samitis are constituted, but the meetings are definitely irregular. The strengthening of and especially the participation at the ward level by councillors is fewer and far between. Although there were some interactions which with the elected representatives, which they have taken special initiative, especially during the COVID times, and they realized that the importance of the elected representatives being a bridge between the system as well as the citizens. Yeah, so that's all our findings were. I guess Akhila, who's done work, and their organization has done work in Bhubaneswar specifically, would talk more about how collaboration can take place with the ULBs. And Sumit from CARE will talk about the recent progress which Bihar has made, because he's representing CARE, and CARE has been an integral part of the Bihar health system for the last 12 years. So they can throw more light on both these states. Thank you.
Thank you so much, Mr. Guha. Ladies and gentlemen, we're now joined by our chair for this session, Ms. Urvashi Prasad, who's the director in the Office of the Vice Chairperson at Niti Aayog. She's had extensive experience in health, nutrition, sanitation, gender, and public policy, and she's been part of the core team supporting the work of the Government of India's Empowered Group 1 for managing the COVID-19 pandemic in India. Ms. Prasad is a member of the World Economic Forum's expert network and co-authored India's first voluntary national review presented at the United Nations High-Level Political Forum on Sustainable Development in 2017. We've had one presentation by Mr. Guha, and we're now moving on to the next presentation by Dr. Kamala Ram Mohan, an assistant professor in pulmonary medicine at the Government Medical College, Thiruvananthapuram. She served as a pulmonologist in the Department of Health Services for 8 years and as a research officer for the India MDR TB project. She also trains and teaches medical officers and health staff in the state health services and is a member of the technical committees. I'd like to now invite her to share the decentralization journey in urban Kerala.
Good morning. First of all, let me thank the organizers, HSTP, Rajiv sir, my mentors from HAP, Dr. Ramangutti and Vijaykumar sir, for giving me an opportunity to present before this distinguished audience. So I'll be sharing the report or the findings from a study, which is a sub-study of the major one that was done by the health action by people. So I'll be looking at the Kerala experience with urban health and decentralized governance. To introduce the subject, in the past decade, as per the 2011 census, Kerala has had a very rapid urbanization and almost 92.7% increase from 25.9 to 47.7 percent of urbanization, and this has brought about a large number. It has widened the inequity between in socioeconomic as well as health inequity. And again, Kerala has 978 Grama Panchayats, 152 block panchayats, and 14 district panchayats, also 60 municipalities and 5 municipal corporations. And with the decentralized governance, the secondary and primary and secondary healthcare facilities were handed over to the urban local bodies. And these urban local bodies actually deal with a lot of wide range of health issues, and also the major focus is on water sanitation, drinking water availability, waste management, and sanitation. And the urban primary health centers were implemented by 2014 in Kerala under the NUHM. And this study explored the role of local government institutions in the urban health sector of Kerala. So it was basically a qualitative study, and also the secondary data on health finance was also analyzed. And it was basically focused on the municipal block panchayats, municipalities, and also corporations in South Kerala. And we also did 29 in-depth interviews were done, and it was analyzed using deductive analysis. And first of all, I'll discuss the secondary data. And this was the fund allocation and utilization by the urban local bodies from 2014 to 2020. And as you can see, of the total amount allocated, the utilization was only less than just below 50%. And the maximum was, even though the allocated fund was only less than 20% for nutrition, the maximum expenditure was for nutrition. That's almost 75%. And all the allocated fund for drinking water, sanitation, waste management was all underutilized, if you look at it. And this is a chart showing the percentage-wise utilization for the different local bodies. That is, you can see that the drinking water utilization was maximum by the corporation, as can be expected, and nutrition was, the fund for nutrition was maximum utilized by the district panchayat. And this is the amount allocated for the urban health institutions, and the proportion which was allocated was, the bulk of it went to modern medicine institutions, that is almost 75%. But again, you can see that it's only 55% has been utilized. And Ayush, which was allocated 25% of the total funds, actually utilized more than around 65%. And of all the funds allotted under the different domains, human resources, which was allocated only 2%, utilized the maximum, that is almost 72%. So coming to the in-depth interviews, we interviewed almost 29 people, ranging from the president to the Harita Karma Sena member. You can see the profile of the interviewees here. And the major domains that were identified was fund allocation and resource mobilization, drinking water and waste management, challenges in project implementation, healthcare of vulnerable populations under the urban local bodies, and Kudumbashree and community participation. So coming to the first theme, for fund allocation, as expected, there were many roadblocks, and there were also efforts to overcome roadblocks. The major identified roadblock was obviously fund allocation, and probably the disproportionate way it was utilized. You might understand why it was so. And they also brought about, highlighted the aspect that somehow the fund dispersal would be delayed, and this would actually hamper the project implementation. And there were instances where the medical officer or the panchayat would have to, panchayat member would have to chip in and pay the money from their own pockets. Even though it's a laudable effort from their part, it's not a sustainable one. And another factor which was highlighted was fund allocation for the women in urban block panchayat is only 5%, which many claim that there is lack of flexibility, and even though the proportion of the women in the panchayat may vary, the fund allocation remains only a fixed amount. And some of the innovations was the panchayats outsource the lab investigations to private clinics with MOUs, and which kind of reduce the out-of-pocket expenditure. Then they collaborated with other local bodies for raising funds for specific projects like a dialysis project, where each level of urban body would chip in with a specific amount. Then funding palliative care through lucky draws or fundraising by food festivals, or helping self-help groups making and selling food, etc. So coming to drinking water and waste management, which was another theme which emerged, the priority, unlike that of the rural panchayats, this is a priority area for the urban local bodies. And the municipality per se manages centralized water supply, and wherever it is not available, they help by constructing wells or pipe connections extending beyond that. And they also help in waste management by providing kitchen bins and composting facilities. And they have also attempted to implement the green protocol and install mechanism for waste management. So some of the challenges in project implementation, there were some sub-themes. That is, the major thing that was highlighted was low autonomy of power. There were so many players, and the urban local bodies could not take specific decisions on how to implement, or there will be fund issues like that. And then also there was confusion in identifying beneficiaries for certain projects. This was specifically more so for the marginalized community or the tribals, because the list would come from the higher authorities, and they would not be able to make changes at their level to allot fund if found needed. And then the concept of conflict of ideas among stakeholders, because one of the factors would be the medical officer would like to, he would be identifying certain problems and putting it before the local body, but they would not be so convinced as to the need for the projects. And sometimes when these officers or the panchayat members change after election or after transfer, the momentum of the project would not be as much as expected. And then there was a issue raised by some people, especially lack of awareness or sensitivity, specifically regarding gender-based projects, where the local representatives would not be so much convinced about the need for such projects, and they just fizzle out after some time. Of innovative ideas, because most, as you can see from the utilization, most of these projects were more focused on nutrition and healthcare, and not on specifically on healthcare delivery, more on and also maybe waste management and water supply. And there were instances of duplication project implementation and thereby resource wastage. And they also noticed some inconsistent distribution of expensive medicines, specifically for chronic diseases. So the fourth domain was health-related activities, specifically for marginalized population. And as I think it was discussed yesterday and also today, the coastal communities, the tribal group, etc., they receive less amount of prominence. And though they provide, the municipality and block panchayats provide ration, subsidy, educational support, etc., it's most often not adequate. And women's health is one aspect which was probably got less attention. And though the nutrition projects are there for the pregnant and lactating mothers and children, and the other aspects like provision of a very wonderful session earlier today. Palliative care, though it may not perform as much as he expected, this is one of the aspects in comparison which has performed well under the urban local bodies. And some of the projects like Vayomitram is a prominent project for the elderly care. And they also provide, as he has already mentioned, concentrators are being supplied for the chronically ill respiratory patients, and it is actually a very big service, even though these concentrators might be redirected for use after the COVID wave. And the last theme is the role of Kudumbashree and community participation. Of all the self-help groups, this has Kudumbashree is the largest one in Kerala, and though they are not directly involved with health, they are involved with a lot of preventive aspects like so part of the Kudumbashree network is involved in sanitation and waste management activities. So to summarize, decentralized governance system, as you can see, is weaker compared to the rural local governments, and the lack of autonomy that of Grama Panchayats is found to be a contributing factor. And rather than providing health care facility delivery, they are more focused on micro sectors like drinking water, safe sanitation, and waste management. And they have the urban local bodies have made for use. And community participation and participatory governance, which are the backbones of decentralized governance, as they say, is not so effective in the case of urban local bodies. And Kudumbashree has emerged as a strong pillar for community participation and supports these ULBs in their work. And these are some of the few recommendations that came up from this small study. That is, I think probably resource allocation should be proportionate to the expenditure and maybe to some extent maybe flexible, providing better financial and administrative support, improving resource availability, providing more autonomy to the ULBs, and improving community participation. And I think more focus should also be given for minority groups and women health. Thank you for your patient listening.
Thank you so much. We're now going to introduce our panelists before we ask them to engage with each other. So allow me to just quickly make the introductions. Mr. Sumit Kumar is the Senior State Program Manager in Care India's Bihar Technical Support Unit, lending technical support to the government of Bihar in Patna. He has more than 16 years of experience in managing and implementing complex health and natural resource management programs in partnership with the government, development agencies, and the private sector. Ms. Akhila Sivadas is a founder member of the Center for Advocacy and Research, where she brings her varied experience as a researcher and communication expert on issues related to gender and development and its impact on the lives of marginal communities. She has also been actively involved in empowering urban poor communities to improve access to basic services and schemes. Ms. Sivadas has also assisted national and regional institutions in preparing strategy documents on gender, child rights, and reproductive health. Dr. A. Sasikumar is a medical doctor who started his career as a medical officer and is currently the Corporation Health Officer at Calicut Corporation, Kerala. He has experience both in clinical practice and in public health. So I'll hand over to Ms. Prasad now, who will then steer the panel discussion.
Thank you so much. And it's a pleasure to be here Apologies for joining a bit late. Before we get to our panelists, we've had whatever I heard of the presentations after I joined in, really, informative and really important learnings. And just to say, because, I come from a public health background, and even previously I have worked in the urban space extensively, programs for the urban poor. So this is clearly a very, very important area. It's not a new area. I think we've been talking about decentralization, per se, for a very long time, including in the policy space. But it remains a very, very big challenge for us across various, cities in the country in terms of how do we really build the capacity of the urban local bodies. How do we get communities engaged? That is a really important aspect. And we heard a little bit about that in the presentations, that there are marginalized communities, there are women, and how do we really get those voices represented? It's the urban context is very different from rural areas. It's very different from how community structures work in rural areas and so on. And then, of course, looking at various aspects, whether it's fund use, whether it's deployment of technology. And I think the perpetual challenge we have in governance of stakeholder coordination, how do we get that to happen? And given that the ULB level is perhaps one where it's most crucial that this collaboration or coordination across different stakeholders actually happens. Because it's perhaps, one of the closest levels to the implementation arena. So I think, a lot of these challenges face us. And then, now that we've also had the pandemic, I think there's a renewed discussion, especially when it comes to health and urban settings, and how do we build the capacity when it comes to public health in particular. And how do we, not just everything, from strengthening our surveillance systems to getting communities more involved, to building more capacity. I think all those discussions have now got some renewed attention, which I think is very, very important for the future. So I have a fantastic panel here today. And I'll just pose some fairly broad questions to them, because they all have very varied and extensive experience. And then towards the end, hopefully we'll take some questions from the audience as well. So I'll begin with Akhila ji. She has so much extensive experience in this space, very diverse experience. So over the years, what are some things that we've actually managed to do well, perhaps? And where do you see the biggest challenges remaining? So that, I think, is my first question. And linked to that would be, how can civil societies, really play a role, really strengthen this whole process of devolution and, strengthening capacities of urban local bodies? So, just any insights from your extensive experience.
Thank you, ma'am. In fact, the last one day, yesterday, very rich discussion on decentralization. A lot of it is in the rural context. The urban context is still untapped. We still don't know enough about what works, what does not work. But, there are compulsions and imperatives, and, wherever there's a vacuum, somebody enters. Civil society has been very strong in that space. Two things I want to preface, ma'am. Yeah, today there was a sort of a sharing by an expert who said, are you over-romanticizing? Are you over-glorifying? Every milestone that we achieve, it takes us one step ahead. There are deep learnings, and an exercise like this is precisely to harness the best. So in the background of that, the whole is still a big daunting challenge, ma'am. Get any of the programmatic, there are hundreds of programs across sectors, and they're not to be poo-pooed. They're very, very critical. They're actually helping. They're all pathways. There's a huge opportunity to leverage each one of them. And what are you getting in terms of governance? Yes, administratively, some departments, some agencies are anchoring it. Then there's a whole set of implementers down the ground up to the frontline workers who are both anchoring and implementing it. If the program is voluminous and you have to reach out to thousands of people or lakhs of people, then something called an intersectoral coordination kicks in, which Shaumik was talking about. And all kinds of vehicles are then put into operation. And one major vehicle is the self-help groups. Asked to support that program, to scale it up and strengthen the governance. But at the end of the day, is that enough? Not at all. It's actually, in many ways, a knee-jerk response to a much more, deeper problem. So what we have done, ma'am, and some of the success in Bhubaneswar is due to the quiet, steady work they've done. Civil society, come and go, but communities are there forever. And we are running 2 projects, one on inclusion across all social entitlements. And in the urban context, you cannot do it without the urban local body, whatever the verticals may be. And the other is the inclusion across all WASH services. On both, the ecosystem has been very positive in Odisha. That goes without saying. And there are innumerable examples of ecosystem. This amendment was passed in 1974. It's not like we are discussing an issue that just turned up or cropped up now. And what we have done over there is looked at the whole governance. That is, how do you penetrate to the last person, the most in need person? And what we have done is we have set up 2 levels of structure, ma'am. One is what you call a single window mechanism, which is run both by the community representatives and the project team, largely by the community representatives. These single window forums are then organically, or they emerge out of what is called a community operating structure, which is at the slum level, all volunteers. This is completely volunteers. There's no paid service. This is, I'm volunteering to improve my quality of life. I'm not volunteering to run a program. I'm volunteering purely out of my own self-interest. And if I don't volunteer, my children are going to be in the same, set of misery that I am in. So that's the logic, and it's a very sound logic. So these community operating structures are divided into 2 kinds of structures, ma'am. One is the Community Management Committee for the WASH. WASH is like housekeeping. You have to do it every minute. If you don't, you'll feel you're in the midst of a typhoon. And the other is a help desk that works across each of the schemes and programs. Anything between 15 to 20 members staff that structure. They're trained, they're skilled, and trained and educated from the horse's mouth. The departments, the stakeholders, the implementers come and train them. There's nothing called CSO training. We are like facilitations. We are not the owners of the program. Owners are the government and the community. So they better get along with each other, learn with each other. And in a place like Bhubaneswar, about 165 or 170, nearly 170 Mahila Arogya Samitis were activated by these help desks. They go defunct, ma'am. They said what more to do and how to keep it going. How do you keep the momentum going? It is the help desks that have activated them, got the untied fund, because if they're not active, the money doesn't come. The banks don't open the account. It doesn't become a reality. It stays on paper and stays like a possibility. And this lot of people, there are about 86,000 population that they've reached out to, ma'am, out of which 67,000 were educated about around 20 health schemes. Very, 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 practical and very essential schemes. If you don't take it, then it's really your loss. You need to take it. So there are about 20 schemes, and out of that 60,000 people they reached out to, about almost 30,000 have been linked to the schemes and services. It operates like a community bureaucracy. In fact, in many ways, it's more efficient than the actual bureaucracy, because they are divided. They're distracted. You know, their bandwidth is very low. Their ability to, absorb shocks is very weak. They really don't have it in them. They break down. They have a meltdown. So, we can't estimate from them. It is these community duty bearers, ma'am, that have been working on it. Almost all of them have been, reached out to, particularly on non-communicable diseases. There's almost a movement happening on the ground. And that is the reality that we are talking about, ma'am. Unless decentralization is supported, I mean, decentralization is the only pathway for community engagement. Nobody is going to take communities seriously if, that whole pathway is not created, because you need systems and structures. You can't just, do things casually or in your own way. And while we, strengthen decentralization, there has to be an equal amount of appreciation on how do you build social capital beyond a certain program, scheme, and service. And that is what has happened. Yeah.
Okay.
Thank you, ma'am.
Yeah. Thank you. And, I think those are very practical insights, from your experience in Bhubaneswar especially. And I think I really, think that this whole idea of government and communities, learning to and engaging better, because ultimately they are perhaps the most sustainable in a way, right? They're always going to be there, as you said. And civil society, of course, has a very important role as an enabler, as a facilitator, as you rightly said. So thank you for those insights, ma'am. I'll move to Mr. Sumit Kumar, and similarly to hear about your experiences from Bihar, because obviously CARE has been working there for a very, very long time, and you would have also seen a lot of changes and evolution happening. So in addition to that, some of the recent or relatively more recent sort of initiatives that we've had the Finance Commission, talking about devolution, and especially in the context of health. And then we also have some, relatively newly launched programs in the health space, like the Health Infrastructure Mission, etc. Do you see any potential, in terms of these programs in the context that we are speaking today, how we can leverage these programs to sort of further our goal in this context of, decentralized governance, and where do you see that potential? What can we do, you think, to, really leverage these initiatives?
Yeah, thank you. So I think Bihar has made a lot of progress in terms of HR, health infrastructure, service delivery, and overall quality of service delivery. I've been working there for last 12 years, mainly in a technical support unit supporting government of Bihar in reproductive, maternal, newborn, child health, Kalajar, and also in the urban health domain. Although urban health is a newer area for us, and we were working together, Shomik ji, Shyamal, we were working together in a consortium led by Janagra, where they were mandated to work with Department of UDN and also urban health team, and we were focused on mapping and infrastructure assessment of all facilities. So as a follow-up that, I would like to tell you that around 12,000 health facilities were mapped and assessed by us. And based on that, government prioritized the construction of newer facilities under the 15th Finance Commission, AB, BHIM, and NHM. So lot of newer health and wellness center are getting constructed. I remember in 2013, when co-chair of Bill and Melinda Gates Foundation visited Bakhtiarpur PSC, and the then additional secretary and MD NHM were also accompanying her. And when she was looking inside the labor room practices, she was very furious and came out and was literally scolding the medical officer in charge there. I was almost sitting next to him. And she was telling that why you are not having staff nurse inside the labor room. And the medical officer in charge was telling, yes, ma'am, okay, ma'am, yes, ma'am. And then I responded that, ma'am, we don't have staff nurse in rural Bihar. Now we have a community health officer across health and wellness center in Bihar. So lot of changes has happened, lot of positive changes has happened. So that's a very good thing. I heard people talking about SHG's involvement. Now we have more than 1 million SHGs in Bihar. So I think, and overall, lot of newer things are happening. SHG run canteen are providing quality meal at government hospital. So it's a new initiative which government of Bihar has taken. So these are the newer thing which I would like to highlight. Thank you.
Thank you so much. Moving on to Dr. Sasi Kumar, completely different state, Kerala, and one I think we, always hold very highly when we especially talk of the public health, and related systems. So I think we'll be, interested to know Kerala's journey has been, when we look at decentralized governance, what, perhaps can we learn from Kerala, things that we might be able to, take to other contexts and implement there. What have been really the successes or even learnings, things that we could pick up from and scale up or implement across the country. So yeah, over to you.
Good morning, madam. Since 2017, I was practicing as a medical officer. After 2016, I joined this year and administrator, I think, health officer in the corporation, initially in Trivandrum Corporation, now in Calicut Corporation for past 2 months. And my personal experience in a local body, the health department in the local body, not only in the secondary care, we have some different functions and duties and responsibilities. Especially the health officer and my public health team have to look after the solid waste management and liquid waste management, civil registration, licensing, nuisance, all the nuisance. So we are responsible. And along with that, we have to look after the secondary care. Secondary care, in Calicut Corporation, we have 6 urban health centers directly. No other local body having this type of direct health centers. We are running 6 health centers, urban health centers, from our own fund. We are running 6 health centers. Also the system which hand over to us, like 3 FXC, 2 CHC, and 8 urban primary health centers, UPSC. Department, in my own department, we have 21 circle offices, including 3 zonal offices. Okay, so as I told earlier, our responsibility not only in secondary care, we have primordial prevention and primary prevention, also the solid waste, liquid waste, and licensing nuisance. So this type of functions also there. So in Calicut Corporation, last year, we were utilized about 80 lakh rupees for modern medicine purchase and 50 lakh rupees for Ayurvedic medicine purchase, 30 lakh rupees for homeo medicine purchase, 87 lakh rupees for appointing the doctors in contract basis in our the hospitals which hand over to us, especially FXC and CHC, also to run afternoon OP in our own health system. 32 lakh rupees for palliative system. So as our Ravi Prasad sir told, our palliative system is very weak, not based on the population. And none of our multidisciplinary peoples were advised so far to improve or increase our palliative system based on the populations. So that's the major drawback. Also, we were utilized in the view of primordial and primary prevention. We have started to screen, comb up all the community to find out the metabolic syndrome, especially diabetes, hypertension. We were spending about 25 lakh rupees for that. The project is called Jeevadalam and Kaitiri Cancer Detection Programs. Also, 23 lakh rupees we were utilized for Pagalveed. Pagalveed is nothing but just for our old age peoples. They can spend their daytime in that particular place. So they will get 3 times food, also entertainment. So we are utilizing about 23 lakh rupees for that Pagalveed. Okay. Also, last month I started a de-addiction center. I think first local body, we started the de-addiction center in our local body. So we attached in my one of our health center, and we appointed a psychiatrist, also a counselor, and a social worker. So it's running very nicely because the drastic increasing of addiction, drug addiction, especially in the school students. Also, in the marginalized community, we were seen in our local body. Also, we would like to start a yoga center. So the fund is earmarked, not yet started. So last time we were got permission to start 24 health and wellness centers in our city. So about 6 crore rupees earmarked for their infrastructure developments. So the infrastructure development still in progress. So our strength is no other department can bring simultaneously the support of community participation and political participation and an official support. The local body can bring community participation because the politicians are in the local bodies. So they can bring the community's participation. Also, if we get community participation through the political support, the officials can work very peacefully. Also, they can implement the projects successfully. The main constraint to the implementing officers, we won't get within a year because we hardly get 4 months to implement the projects. Because all other days, like more than 6 months, usually takes for administrative sanction, technical sanction, DPC approval, and we have to wait for a long time. So the implement officers hardly get 4 months to implement the projects. That also a major drawback. Also, the technical peoples. We have a public health system, the engineering system is there, but we need a multidisciplinary approach in all the projects. So we need multidisciplinary support from the technical peoples. We have to properly fix the priority and fund allocations and time we need. That's all, madam. Thank you.
Thank you. And I think, Kerala is interesting in many ways, apart from everything that we can learn. Also the profile of health issues that we are facing there, like non-communicable diseases you mentioned, there's a big shift in many of our states, and, like Kerala is one of those. Also, the now increasing population of elderly, senior citizens, because I think it's the southern states which are first seeing that sort of major transition, and that's, go across the country. So I think there's a lot that we have to learn, in especially both those contexts. And, how do we handle NCDs at this level, and what do we do better for our senior issues, for the rest of the. So I think this is such a vast topic. there's a lot more that I wanted to ask, but I want to also give the opportunity to anyone in the room who has a question for our panel. I think we just have a few minutes remaining. So if anyone has a question, please, if you can just, raise your hand. Yeah, I think we have one question. Maybe we'll just take one and then we'll close.
Thank you. Thank you to the panelists for sharing your insights. Just one couple of questions actually. During the course of your studies, respectively in Bhubaneswar, Bihar, and Kerala, did you and your research team get the chance to interact with the community, get their perspectives on their preference of taking care from public facilities? Because especially in the urban settings, people prefer private care providers. So did you get to interact with the community, try to triangulate the finding, especially when, sir, you spoke about Bhubaneswar and said that the urban local bodies are doing quite well in delivering quality health services through the UPHCs. So did you triangulate that finding with the community as well? And do I follow up with the second question, or do I wait?
Yeah, you
Yeah.
can go ahead with
Yeah.
the second question,
Yeah,
and
just-
then we can answer.
Yeah.
The second question is across these cities as well. Were there any differences in the roles and responsibilities undertaken by women in the urban local bodies that you could kind of encounter?
Okay, thanks. So I'll, sort of just emphasize in our study, Janagraha study, we looked at community engagement or citizens' participation, specifically in Bihar. In these other cities such as Bhubaneswar, Chennai, Pimpri Chinchwad, we essentially looked at only the executive side as well as the elected representative side. So technically, I cannot respond to what your question is all about, but we did see a fair amount of engagement at the primary healthcare center level, and also we did have the opportunity of interacting with the let's say the Mahila Arogya Samitis specifically in Bhubaneswar, and we could clearly see and also the elected representatives, we could clearly see that there is a very high level of community participation, citizen participation, and awareness being both generated from a demand side as well as it being responded from a supply side. Now, getting to Bihar context, what we found out was, because I mean, just the demand is so huge, there isn't that classification at the sort of the citizens' end in terms of classification between tiers of healthcare. So, for them, public health or health essentially means hospitalization, right? And our study was limited to its scope in terms of public health at the primary healthcare level. Some of the key sort of feedback was that everyone tends to go. There's a very high degree of out-of-pocket expenditure, and everyone tends to go to hospitals, right? And that too at the private sector level, specifically in urban settings, right? But the distinction between the various levels of healthcare delivery, be it tertiary, secondary, or primary, was not very evident in our sort of findings. So, I mean, that's just for Bihar as well as Bhubaneswar. I forgot your second point on what was it about? If you could just sort of
Women.
so women representation or women engagement, especially at as I said in Bhubaneswar, was very, very extensive. We were just bowled over at the level of engagement in Bhubaneswar, and might I add, even in Chennai, the extent of involvement of elected representatives and the active participation of, and the knowledge which, let's say, the chairperson of the standing committee of health on health at the Chennai Corporation was, I mean, it just bowled us over. So this is some of the things which were the sort of the exemplars, so to say, in our study, and that's what our study sort of has tried to point out.
That a lot of the stuff, the governments have actually moved to the field in Bhubaneswar. There's huge amount of, discussions and planning, micro-planning at the ward level and at the slum level. So, that's another observation that Shomik had made.
Thank you. Thank you. I believe we are completely out of time, so we can, of course, continue the discussions offline. But we'll conclude here, and thank you to all the panelists and the presenters, and as well as to the audience. Thank you.
Thank you so much, Ms. Prasad, for ably steering this session. I'd like to request Dr. V. Ramankutti to please present mementos to our chair and speakers. We'll begin with Ms. Urvashi Prasad. To Mr. Guha. To Akila Sivatas. Mr. Sumit Kumar. To Kamala. Oh, sorry. Okay, you can give this one to Shashi Kumar. To Mr. Shashi Kumar. And to Kamala Ramohan. A photograph, sir, before you leave, a photograph with all our speakers and our chair. Ladies and gentlemen, we've overshot our slots. So what we've done is we've taken 15 minutes off your lunch, and we will now take a break for coffee and return very quickly. Please don't waste any more time so that I don't have to shave off any more time off your lunch break. We'll move into the next session very quickly. Coffee and tea arranged inside the hall. Quickly take your beverage and come back so that we can start our sessions on time. Thank you. Check. Ladies and gentlemen, may I request you to please return to your seats? If you're getting your second cup of tea, you can bring that to your table. Please return to your seats. Calling the House to order. We've still got a couple of sessions to go. May I request our speakers also to head towards the dais? Mr. Seem, Mr. Ghosh. Mr. Huda and Mr. Mohan. Ladies and gentlemen, those of you still standing at the counter, may I request you to please return to your seats. Those in the seating area, please be seated. So we're going to continue with our sharing of experiences of decentralization in other states. May I request those who are still standing outside of the seating area, please be seated. Those at the rear of the hall, please come in and take your seats. So we have to chair this session with us, Mr. Anirban Ghosh, the co-founder of Transform Rural India. Previously, he was on the leadership team at Pradhan. Mr. Anirban is recognized for his role in expanding comprehensive engagement with women collectives beyond financial services and livelihoods, and as a pioneer of automated bookkeeping systems in women's self-help groups. He's known for his expertise in community-managed irrigation, natural resource-based livelihoods, and numerous technologies for development initiatives. Our speakers are Mr. Mohan H.L., a social scientist with 3 decades of experience as a senior technical advisor. He's at present the CEO of the Karnataka Health Promotion Trust, where he leads and provides overall direction to the management of programs, communications, and community mobilization systems and activities. Dr. Tarun Seem, who is a medical graduate who then became an officer of the Indian Revenue Service and currently serves as the Commissioner of Income Tax. Dr. Seem has been the director of the National Rural Health Mission at the Government of India and head of the Health Systems Support Unit at the Public Health Foundation of India. He's also served the Delhi government as the Director of Health Services and Secretary Health, where he mentored the Mohalla.
In that particular state, there is a high chance that the improvement will happen at the village level in terms of improving the ANC, PNC registration. ASA will function better, and the institutional delivery that happen in the public facility, and out-of-pocket expenditure also reduced.
And you found correlation for this? You found correlation for well-participating villages to be?
Yeah, that's why I'm talking about when when you have a I measured one kind of parameter. I could not show because of this time constraint, but I measured looking at 20 parameters and measure a level of decentralization in index, looking at all kind of parameters, and then I find the positive correlation.
Put up that slide for the
2-3 slide if you see if want to.
There is a correlation slide on his.
So another important point, let's say then I divided, the level of decentralization, let's say low level of decentralization and high level of decentralization. And now you look at the community. In high level of decentralized village, so what is happening is that, the low socioeconomic stratum groups are getting more access of public facility and other kind of, including this JSY scheme benefit and all kind of, the stuff they are getting. It's not that in Haryana that reservation matter or women representation matter. It's the how, the local community and level of decentralization that is more important. So what I would suggest of things, you have implemented at the ground level. If a sarpanch, including male or, the elite or, so these were some kind of, the indicator that I was using. You will not be able to, read all these kind of things. So these are, the related to, the VHSC,
So
and, the composition of VHC.
if you can go
who
to
play
the
major
correlation
role,
slide, I
ASA
think.
worker, Anganwadi worker, and training program organized kind of things, and these things were there.
Yeah, the
related.
correlation slide, if
The
you can go.
correlation.
Next.
Please go ahead. So this is the degree of community participation that I estimated in village level. Please go ahead. Please go ahead. Please go ahead. Please go ahead. This is the things that if you want to, look at, the how in 10, at all India level, only 17%, the VHSC in village. 17% village, they are engaged in all kind of 10 type of, the functions. Please go ahead. So I have to show the relationship. So this is a comparison between these things. Please go ahead. Please go ahead. Please go ahead also. This one. So this is a kind of, the kind of regression that I multinomial logic regression that I try to put here. And I found that, the wherever ASA worker or VHSC, Gram Sabha engagement, degree of community participation and level of, the decentralization is high, there is high chance that, there are a lot of improvement in, the ANC, PNC, institutional delivery and out-of-pocket expenditure. Please go ahead. Please go ahead. Please, one more slide I have to show. Another one. Another. Please go ahead. Go ahead. Go ahead. Please. This one. So I was interested to show this just relationship. The low. Living in, the high infrastructure districts in that area. So that make a significant difference. This is the kind of relationship
So
that I was interested in.
it makes a very strong point, which many of yeah.
Yeah. So let's. So no need to show. I think. So no need to. I think read this.
So you can actually, the presentation will be shared. You can look at the figures actually. If people with statistical bent of mind, you'll find a lot of data into that, which makes a very interesting, as practitioners, we keep on, saying that lot of villages, if the participation and the engagement of the local bodies are strong, it will impact the health outcomes, whether or not there is actual, devolution in the de facto manner. So, and this kind of correlates a lot with my personal experience in Madhya Pradesh, Chhattisgarh, Jharkhand, where there is no formal devolution, but with very active participation at the grassroots level, both the quality of facilities, the quality of services, and eventually the impacts in terms of the numbers are quite different in those kind of places where active communities start engaging very actively with the health system. So it's a very interesting study which you have done, even in a place like Haryana, where we know about the strong patriarchal and the caste hegemony in rural Haryana. Even there, this is visible with active participation, significant differences as being shown. So if we can move to the next round of discussions in terms of looking at, building from the point which Dr. Shailendra talked about, that there are some spaces and some pieces around which if programs are created, it will possibly have greater engagement, involvement and participation of communities on the ground and greater say and voice of communities in the health outcomes in the local area. So Dr. Tarun, I wanted to bring you in that looking at the entire health space, both the there is this whole one space of active behavior change within homes. Second space of OPD, kind of where you are going for a curative services, but of a which doesn't require an IPD engagement. And then there is an IPD engagement. So in this continuum, where do you see or what are some of the engagement spaces you see where communities and local leadership can play a strong role?
It's easy to answer this. There are three things: nutrition, drinking water, sanitation. Period. If we stop at these three, we would have cracked it. Because these are three which can be handled at the family level. Nutrition as well as, and I'm talking not just the school nutrition, but the pre-Anganwadi nutrition, even before the child is going to the Anganwadi. And then also including the woman's nutrition levels, so as her BMI improves. And then the drinking water. So if these, and drinking water continues into the school. So the sanitation, drinking water and nutrition are key areas in which I believe the community can easily engage, fruitfully engage, because all of these solutions will be highly location specific, cultural propensity specific. And of course there'll be role of procurement involved, but that will all be local procurement.
And going beyond that, these are determinants of health in the actual health space.
These are the health. These we call them determinants, but that reduces their relevance actually. These are health. The entire Western world developed its health system on basis of this only. So we got to solve these.
Dr. Shailendra, on this question of what are the spaces, one space you talked about that NCD targeting is possibly a space. What are some of the other spaces you see where communities can play a very active role in moving the needle on health indicators at the local level?
Okay, so see one more, what we see when it comes to this kind of whether it is a health indicator or it is social determinants. See, when it comes to family, when it comes to village, they are the people actually the receivers of all this, whatever intervention which government is doing. You see that how the intervention happens. WCD, women and child, they have their own way of dealing things. Health, they have their own. Education, they have their own. Nowhere it meets together, right? Then, but the same people, the people who get benefit out of it, they go in each level, right? So decentralization is the one mechanism where things need to converge, has to come there. If the child marriage has an implication of maternal death, or it is the infant death, to work together. So one opportunity what we got in this, because that's the reason I advocate strongly for the decentralization. So that is the only way forward, together as one at the lowest level. So otherwise what happens, these parallel committees creates havoc, and which is creating. Now we recently, I think, I remembered Vijayanand sir paper, the first people's planning paper, still I refer sometime. Rajiv Sadan sir, last time when we had a discussion, now the aim started in the state. Okay, somebody was talking about directorate is completely defunct at the state level. See, I can quote 100 of institutions how it is defunct. because of the centralization. We talk about urban again. I will tell you, urban, there is no clear clarity in what we are going to address in the urban. The government, even the health department, they themselves are not defined, the metro cities and the municipalities or Patna panchayats. The strategies are same. Everywhere we are calling as a mass. Actually, mass is nowhere. That is the reality. So, if at all you want to tie up with some kind of a structure, the city itself need to be divided completely differently. So then you can plan what the community participation, how we can ensure at the lowest level to the top level. Because when I'm talking about participation, I'm not talking about the lowest level alone. The participation need to happen at the city level, zonal level, ward level, and the below level. So we don't have any clear strategy. See, if that is happening, then the convergence also start happening, because different people will come together. There is a platform to come together and discuss. Okay, I can take the Kutumbashree example. It is such a good example to bring everything together. But in many of the states, we don't have that kind of an example. We need to create that through government guideline or the order, which especially urban space, we don't have that. Even rural parallel committees are there. To give one example, 14 districts when we are implemented this for a year, just for a year. And we did the study with the control district also. We can see around 25 to 30% difference in the screening itself. Because there is for NCD screening or TB screening, everything. Okay, they are able to fulfill because of the panchayat's role. So this is an evident. Now we are doing more scientific. It is true on the VHSNC, which we did 10 years back when VHSNC came. But I'll tell you, we talk about Janarogya Samiti at the Health and Wellness Center, which is Panchayat Adhyaksha is an Adhyaksha. But last few years, the power of finance, whatever VHSNC untied fund and Janarogya Samiti, it is withdrawn from the president's, earlier president is in a joint signatory, now it is withdrawn. What we are saying, we constantly need to fight to keep that into the decentralized level. So this fight will continue, it won't end up. But we need to have a strong belief of that what we can converge, and the people look at it one. They don't see you are from this department, they are from that department. They see that, okay, this is something I am getting which need to be collectively addressed. I think that is what something which I learned through this process. Thank you.
Thanks, Mohan. Great points. Dr. Shailendra, what do you think are some of these spaces through your study and your engagement where communities can really take a leadership in terms of moving the needle on the health indicators?
Yeah. So see, generally in the village, in the context of Haryana, I'm telling you, so they largely engage themselves through the Gram Sabha. So this is the the most effective, powerful tool to engage with not only with our elected representative, but also with the health functionaries, because they have to sit there in that. So that community that can make the significant difference. But the point is, when when elite and powerful people gain gain more hijack the decentralized power, then it make no difference, or you can say the worst impact on the outcome that we are expecting to. So this is the only thing that I can add to relating to the community participations. And if community is aware about their things, so that our health functionaries or our health center should be well or effective to deliver all kind of services that is required. So then the things became the easier for people, and the sarpanch has to react accordingly. And sarpanch and all representative, whenever the MLA MP came in their village, and on CMO and other people also visited their village. So immediately they engage with all these. This is the requirement that you have to fulfill. Like in some of the villages, the medicine were not reaching to the desired people, and even sometime, this doctor were selling whatever medicine they were getting, they were selling here and there to, through their own clinic. And through this community participation, they could make a significant difference. And after this kind of engagement, things improved a lot. Most of the people, those who were going to city for the outpatient visit, they were going to the PHC. So these things, happens when, the community aware about their own right and responsibilities. Thank you.
Yeah, interesting. So, if I can add to this, in our own experience of working in MP, Chhattisgarh, and Jharkhand, another space where I thought communities have started playing a role, especially in Jharkhand, last 2 years we are seeing that after this 15th FC engagement came in, identifying gaps in the health and wellness centers. So that itself large in several districts, we were able to see the local leadership with little bit of training and support, they could actually create the gaps which are there in the facility which exists in my panchayat. And detailed gap analysis they were able to create, which have subsequently been funded through both 15th FC, PM ABEAM and NHM's own budget. So that's one space we thought instead of having copy-paste kind of gap analysis being done at a district level, actual participation of leadership could happen. So that's one. Second, we found that after the 15th FC, there is a new space in the guidelines itself to have plans which are beyond a Gram Panchayat level. Across the country now, that is available at a block and district level. Yeah, at a block and district level. So several districts and several blocks, people have created, infrastructure investments coming in from the 15th FC, like digital X-ray machines and things of that kind. The third space we found was around the VHNDs, oversight around the VHNDs using digital applications. Several places, Jharkhand has actually made it mandatory to have few observations of VHNDs coming in through the SHG system over an Android-based platform, on which salaries, processing of salaries of government staff are based on some of the outcomes which are there. So these are some of the additional spaces I thought where communities can play a very active role. So we are at the end of the time. Should we hand it back to you, or you have time for a few questions? Okay, yeah. So can we have maybe 2 questions? Yeah, please identify yourself and your question, please. Can somebody give him the mic?
This is rather than a question. I'm Raman. I'm from the Public Health Resource Network. And rather than putting a question, I'm putting a reflection which I would like the panelists to further reflect upon. One is, the interesting and important thing that the issues of coordination between the health department and the urban local bodies. How are these handled by various states sitting here, and also that could be a good learning for other states which are listening or which are going to listen maybe. So I'm from my experience of working in Uttar Pradesh, Uttarakhand, Orissa, Jharkhand, Chhattisgarh, and various other states. One of the important thing is that the health department's own mandates and the urban mandate, they don't go together, and that makes a major problem for any program that is, and I was also part of the National Urban Health Mission's task force, and one of the important thing that we had suggested at that time, how to coordinate between the people's representative that is coming in the next session, but it is important to note here also, how to make the people's representative from ward member to standing committee chairpersons or members to chairpersons or mayors, that entire group in the urban segment is quite important. And training of them, their involvement in these processes, how are either in Mohalla Clinic or in the Karnataka experience or in Haryana, how are these things done is a very important thing to understand. Thank you.
I don't have an answer because I have not seen any good model on that as of now, especially in the urban space. But what I can share recently of developing some kind of a guideline for the urban community structure, what you are suggesting, which is part of it, and both at the different, because we divided like 1 million and placed it, they don't know how to use it, all blah, 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 so many reasons. I'll tell you, when we entered, because that is funding we received from other source, we told, see, our belief system, when many of these all equipments, the so-called elite people, rich people will keep in their house. But why can't give it to poor people? Okay, they can manage, number one. Number two, the same people claim that 80% of the people can operate smartphone. See, everybody uses for their own convenience, the rural people. We know the reality, how many people have mobile and how many people uses. But when it comes to pulse oximeter, they have almost this thing, number one. Number two, when it comes to the procurement, recently in Karnataka state, we had in a comparison that how many hemoglobin meter is available at district and below. And we gave, because we are already, government is given 6,000 kit, there is a 6,000 hemoglobin meter is there at Panchayat. And I'll tell you, the health department didn't have so many. You know why? The procurement is decentralized, so they are able to procure, which government at the state level still not able to procure. They are struggling last from 6 years. So this is the issue when it goes to, see, that's why that is in a belief system which, if decentralized things, because people always talk about, yeah, corruption, so many other things. I was always used to tell, let it corruption also decentralize it, right? What is wrong in it? So people, let us take it that, why you have to eat? Let them also eat, right? Because there is a people question. Because 400 people vote, 400 people know this fellow made money. That accountability is there at the lowest level. What is there in the upper level? So I think we need to have that strong belief. Ravi, I don't know. I was yesterday, I'm having an argument. We'll continue that argument. But this is the belief system which we have. Thank you.
Thank you, thank you. I think we are already over time, so we'll hand it back to the host.
Hello, sir. Am I audible?
Yes, you are.
Yeah. So my question is, in urban areas, so many people.
Just move the mic closer, please. Yeah.
Yeah. So in urban areas, many people utilize services from the private sector also, and they have to pay for service. So in private sector, that leads to out-of-pocket expenditure, and that is also in rural areas. So, sir, I want to understand in terms of decentralization, what is the role of maybe the local bodies in engaging with the private sector so that we can address this issue of out-of-pocket expenditure?
It's a very large question which has yet not been fully, it's only an emerging space. There are a lot of startups who are coming in, Davados and iCure. You'll find several of them who are providing, attempting to provide, OPD services at a reasonable price point. But the question is that how do they interact and how do they complement, supplement the public delivery system is still an open question. There have been experiments which are happening in different places where like Rajasthan government actually brought iWish into their own system, or IQ, or also Jharkhand government is pulling them in to deliver certain services on the ground. But it is still a very, very live, open question, and not much has been talked about it. So maybe some studies on this to highlight this issue will be a good starting point. Thank you.
Also, I'll just take
half a moment. In Delhi, in Mohalla clinics, you get 80 basic medicines, 212 tests, and a consultation by an MBBS doctor. You pay nothing. And you give no documentation. And in Delhi, there were large number of areas where the chemist shops were showing much lower sales than before the clinics came up. Many of the Jhula Chap doctors had to escape because they didn't get any business, because you can as well go to an MBBS doctor for which जो आप पहले दूसरे डॉक्टर के पास जा रहे थे. So in terms of a functional model, there is available if you are able to give without any documentation these basic services completely gratis. It's taxpayers' money, that is.
Right. Thank you very much, Mr. Ghosh, and speakers for that tight panel. I'd like to request Mr. S.M. Vijayanand to please present our speakers and our chair with small tokens of appreciation that we have. We'll begin with Dr. Tarun Singh. To Mr. Anirban Ghosh. Just a minute. We're taking a collective picture, so it's... Dr. Huda and Mr. Mohan. Mr. Vijayanand, please stand in the center and have our speakers join them. You can take a group photograph now. Make the changes. Thank you very much. We'll just quickly move into the next session where we have sharing of experiences from a few elected representatives. Just place these, please. And if I could request our speakers and our chair to please join us on stage. Mr. Abdul Wajid, Dr. Pandurang Patil, Ms. Meher Heather, and Mr. Matumal Salim. There are chairs. There are chairs. Please come up quickly. Okay, I believe Mr. Salim is not well, so we'll continue with the panel now. To chair this panel, we've got Mr. Abdul Wajid, the former councillor of Bruhat Bengaluru Mahanagar Palike. Widely recognized as a people's leader, he has led efforts Widely recognized as a people's leader, he has led efforts to improve the physical and social infrastructure of the city, improving access to entitlements in health, nutrition, and sanitation has been a key area of engagement for him. On our panel, Dr. Pandurang Patil has served as a mayor of Hubli Dharwad Municipal Corporation, has also been a council member 6 times. As a member of the Hubli Dharwad Urban Development Authority, he has overseen efforts to ensure the sustainable and planned development of the twin cities of Hubli and Dharwad. Dr. Patil is a medical doctor and an experienced city representative, so is uniquely placed to talk about urban health. Ms. Meher Heather is a community leader, a former councillor of the Municipal Corporation of Greater Mumbai and chairperson of Disha Foundation. A passionate advocate of women's health and education rights, she is focused on improving the lives and prospects of underprivileged girls in her community. We have an addition, and we are really indebted to the former mayor of the Bellary Municipal Corporation, Mr. Ibrahim Babu, who's agreed to join us on the panel and stand in, as it were, for Mr. Salim. So, Mr. Babu coming in. Thank you. So it's over to you, sir, to steer that session now.
Good afternoon, everybody. First of all, I'm thankful to Janagra and HSTP for having invited us here. You have been heard from the government officials, you heard from doctors, experts, advisors. Now it's turn for the public representatives, corporators here, from one from Mumbai, one from Bellary, one from Hubli Dharwad, and myself from Bangalore. Now we are talking about the decentralization of health. Decentralization, it should not be only word. We have been speaking, we have heard 74th Amendment is not being implemented properly. It's not health. ULBs were not strengthened properly so far. If you ask me, BBMP, Brahat Bangalore Mahanagara we have been controlled by the state. BBMP has very less to say. After this 15th Finance Commission recommendation, now Bangalore is starting with the Namma clinic. It's still yet to start. They have started 100 and maybe they're going to start few more. But on paper it says every 10 to 15,000 population should have one clinic. That's only on paper right now. When we're talking about decentralization of health, we should post-COVID. Now everybody is talking about health. I have discussed before also. Every time now one gentleman was saying now whatever the central government puts on us, we are following. Or whatever state government say, the urban local bodies are following. There is no power given to the ULBs as per as the conduct, as per as the health department is concerned. When we talk about health in BBMP, we talk about SWM, solid waste management. Post-COVID, now everybody has realized that yes, health is an issue. When we talk about thousands of crores, BBMP has got about 10 to 12,000 crores of budget, and Mumbai Corporation has about 30, 40,000 crores of budget. Now we are talking about health. To really strengthen the health issues, we need funds. Now the 15th Finance Commission has come forward. I think the funded will be more. Now let me start here. How we have prioritized the health issues in the corporations, whether the ward committee has been involved, whether the community participation is there, whether mapping is there, and whether UPSC has been supported by the local corporators, and whether really the officials are being cooperated with the corporators. Let me start with our sister from Mumbai, Meher Haidar. Madam, post-COVID, I think Mumbai has done fantastic job, and especially with the slum, Dharavi slum and all that. How you have participate in the issues, and whether the health officials supported you, whether the corporation has supported you, whether the decentralization, what we're talking about, has really helped you in COVID issues, COVID centers, whether it is injections, whether it is isolations, whether it is during immunizations. Can you just put a light on that?
Yeah, good afternoon, everybody. Thanks a lot for inviting me. And before starting, I would just like to clear 2-3 points regarding to Kerala. It's a beautiful place, and myself, I'm from Kerala, my husband is from Kerala. And 2-3 points which I just want to clarify. The one is, Kerala, although a densely populated area, the population is not like UP and Bihar. Secondly, the standard of living, let it be a rural area or you can say, for example, Kannur or Wayanad. The standard of living is same. Although Wayanad is a backward with tribals in it, but I think the standard of living is same. And awareness, the public, they are well aware. They know how to use their rights. Now, for example, in Maharashtra, almost a year, there is no election in Mumbai. And in New Mumbai, almost 2 years. In Kalyan, almost 3 years. But if this would have happened in Kerala, the public would come on the road and they would fight for their rights. But in Mumbai, people are not aware. You, even for migrants, you have medical registration, right? For the migrants, which is not there in any other country. We will take many years to compete with you, but again, I'm a Mumbaikar and I'm very proud to be a Mumbaikar. Mumbai is almost 2 crore population with floating, with the migrants. And Mumbai is the richest corporation in full Asia. The budget which we have, the Mumbai budget, I think so many states doesn't have in India. Now this year budget is almost 52619.7 thousand crores overall. And only for health, it is 6.39 crores, thousand crore. That means 11% of a yearly crore. So Mumbai is one of the, Mumbai doesn't need, it doesn't have a money shortage. Mumbai is a rich corporation. For example, there is a 3-tier. One is central, one is state, and one is corporation. But Mumbai corporation doesn't need them because Mumbai is a rich corporation. I am happy to say Mumbai have 5 medical college, 20 peri-peri hospitals, and 3 central medical college. And we have taxpayer who are happy to pay their tax on right time. But again, there are many lacuna with that. For example, if there is a taxpayer, he wants something in back. He wants a good health. He wants a good structure for it. But I'll say there are many lacuna. For example, there are hundreds of dispensaries in Mumbai. Like you are saying, Mohalla Clinic. So there are hundreds of dispensaries in Mumbai, but you will not find scheduled drugs over there. There are no medicine for BP. There are no medicine for diabetes. No medicine for, like all the local health issues. Medicines are not available in Mumbai. Although Mumbai is one of the richest in fund, it has so much money, 100,000, FDs there in Mumbai for the health. Not health, overall budget I'm saying, is safe. But again, you will see that there are problems for medicine. Scheduled medicines are not available in the dispensary. So people, the local people, they are not aware. They don't go to the dispensary because medicines are not available. They reach the hospitals. Now, Mumbai doesn't have any digital facilities. For example, I am a patient's family. Someone in my family is very serious. I don't have any app or any facility where on a touch of a button I can find out whether there is any beds available in municipal hospitals, any ICU beds are available in municipal hospitals. There are no ICU for outborn babies. Mumbai, although it is the fund, it is a richest corporation, but there are many lacuna in it. For example, now during COVID and after COVID, during COVID, the Epidemic Act was used, Act of 1897, which was used during COVID. That's why COVID was very well performed, managed, and the biggest tool because of which Mumbai was able to manage was due to decentralization. Each ward was decentralized because of which we were able to fight, we were able to manage COVID. The first was we were HR, whether doctors, now it is centralized. If a certain hospital is in need of a doctor, it is centralized now. 2 to 3 months, we don't get doctors in the hospital because it is centralized. The procedure takes such a long time, so where will we get doctors in the hospital? But during COVID, it was decentralized. Doctors were easily available. All the doctors in the ward, the locality, the common locality doctors were easily available. Medicines were easily purchased. Per day, 5,000, a limit up to 5,000 can be used for unforeseen supply. For example, the drugs which were not available were easily purchased. Up to 5,000, that doesn't mean that only 5,000 was used. You can use even 50,000, but up to 5,000. If it increases, you say 5,600, it was again centralized. So during COVID, we had a warehouse where we were easily able to maintain the ambulance and bed. Like if a patient needed an ambulance, it was easily maintained because it was decentralized during the COVID time. We had a disaster room. But again, after COVID, the war room is finished. Again, the disaster room is centralized. Now, how can a ward manage it? If we need a patient needs a bed, it is again centralized. The ward doesn't have the power. It doesn't have ambulance with it because again it's a decentralized logistics supply like medicine and lab, which was decentralized during COVID. Again, it is centralized. Again, if you need a medicine, for example, there's a dispensary in my ward. The medicines and all the needed things are bought down through a lab. But billing process, since it is centralized, the lab doesn't get the money because there are so many problems. So medicine doesn't reach the dispensary. Even we have ASHA workers, but people not aware. Like Kerala, people are aware. In Mumbai, election is not there for almost a year, but people doesn't care about it. They are not aware about it. So there are many procedures which has to be undertaken during COVID. Like during COVID, it was easily managed. There were many SRA buildings which were converted, SRA projects which were converted into COVID hospital. Because of decentralization, we were very easily able to control the pandemic. I'm very happy to say that our former EHO officer is here, Kerkar. Yeah, she would further tell you how it is done. There are many things like during COVID, war house, I was saying about disaster room, which again now centralized. So I think so decentralization is a boon from 74th Amendment Act. Because of that, like for example, if you need a well in a village, you have to go to a collector. But due to decentralization, even the village panchayat can easily construct a well. So a 74th Amendment, which is a boon for decentralization, it is not used. Decentralization is not used. It's a very small and common thing, but which has not been used. It is almost the act in 1992, I think so, it was amended and implicated in 1993. But still 20 years, 20 saal ho gaya hai. But decentralization is just a word. It is not being used. You have to bring it in use. So Mumbai Corporation, yes, richest corporation, it has money, but the public doesn't have awareness. You need awareness. There's not an app. There are now we can say that now ventilators are available because of COVID. Ventilators were there, which was easily, now we have it. But before, there was no ventilators
Thank you,
in
madam. We are
corporations.
short of time, so we have to again,
Okay.
we'll come back to you again here. Now, as per Meher Haidar, everyone knows that Mumbai Corporation is rich. I know we all know Mumbai is financial capital of India. But here, her point is when COVID was there, it was decentralized. I mean, it was everything was towards the corporate level. Now, after post-COVID, again, it's gone back to central level. Now, I want to highlight this as that 74th Amendment says any local body elections which are due 6 months, the election should be conducted. Now Mumbai has no corporation from past 2 years or 1 year. Even Bangalore Mahanagara Palika doesn't have corporation from 2.5 years. So that needs to be looked. And if there are no corporators, then definitely this decentralization doesn't work. Now we go on to Mr. Dr. Panduranga Patil, who is a senior corporator of Hubli Dhadwar Corporation. Sir, can I just highlight on the 74th Amendment as well as the decentralization of power? How did you manage during COVID, or how the health department is cooperating with you, or whether the officials are cooperating with you, whether the government is supporting the Hubli Dhadwar Corporation? Please put a light on that.
Decentralization of powers. The concept begins in the 1982. That was also from the Karnataka. Mr. Ramakrishna Hegde was an SCM of that Karnataka. it started. Then onwards, the decentralization of concept or the conspiracy has been uh, discussed about the country. Then it started accepted by the central government that decentralization system adopted and imposed throughout the country. But what happens? 74th and 73rd Amendment have been passed in 1992. That was in a clearly declared as a local bodies. It means maybe the panchayat, maybe the ULBs. They have declared as in a local self-governments. But what happens from the 1992 till now, there is no government declared as a local self-governments. Financially insufficient, powerly insufficient, totally. With all this, today and yesterday, most of the experts, those study reports, their opinions, they are humble, they have expressed. But all the things put together to continuous, it is a good thing, accept it, exercise it, implement it. The feelings are there, but things come and stuck where? Financial and observations, obligations, and rules and regulations that has been controlled by the Delhi or some other states, capitals. So, this is the only solution for all the opinions that declared, local self-governments by the constitutional power of 74th and 73rd. 74th is in urban zones, 73rd in the rural zones. Whole things, what you learn, what you experienced, and what you are having in opinions, whole things will be implemented and reach to the poor man and the last man of the country. Your concept, your idea, your feelings will be reached to the last person. When it becomes an 73rd and the 74th, implement perfectly local self-governments and can make an rules, act as a government, and implement as a government rules. That is the only situation. That is my opinion.
Thank you, Pandurangan Patil, sir. Now, according to Patil again, here the 74th Amendment, which has come into effect in 1992, has not been implemented properly as such, as far as the ULBs are concerned. Now, let us go to our friend from Bellary. He is an opposition leader in Bellary Corporation. Can you highlight whether your ward committees are functioning and any decisions taken in ward committee regarding health, or any budget is available for the corporators to implement on the health sector? Can you just?
Can I speak in Hindi?
Hindi, Kannada is okay? Hindi, okay. Hindi, okay.
I can talk English, but not fluently. So I can speak in Hindi.
बोलिए हिंदी में बोलिए.
सर और एक टाइम रिपीट करो, आप क्या नहीं?
आपके कॉरपोरेशन में वार्ड कमिटीज किस तरह फंक्शन कर रहा है, और आपको अगर बजट में कुछ हेल्थ के ऊपर कुछ बजट सेपरेट से दिया गया है, और इससे पहले भी आप कॉरपोरेट रहे, किस तरह आप वहाँ पर सपोर्ट कर रहे हैं पीएससी से, या ऑफिशियल्स के साथ आपका कोऑर्डिनेशन कैसा है?
हमारा कॉरपोरेशन में तो हेल्थ के लिए या सैनिटरी उसके लिए बजट है. पहले थे हॉस्पिटल्स, अभी हॉस्पिटल और कॉरपोरेशन का कनेक्शन ही कट होगा. ये सिचुएशन है बल्लारी कॉरपोरेशन का. अभी आप बोल रहे ना डिसेंट्रलाइजेशन, इससे भी फायदा होता है आने वाले दिन में. और कोविड टाइम में हमारे लोकल बॉडीज के लीडर्स थे ना, हमारे कारपोरेटर सब लोग बहुत अच्छा काम किया। कोविड में हमने एक बेनिफिट क्या हुआ बल्लारी महानगर पालिका के, माय फ्रेंड श्रीरामुलु वाज दैट टाइम हेल्थ मिनिस्टर कर्नाटका स्टेट। सो हमने 80% कोविड टाइम में कुछ प्रॉब्लम तो नहीं लगा। थोड़े लोग क्या अफेक्टेड हुए थे, डर डर के लिए अफेक्ट हुए थे इतना बस। लेकिन दैट टाइम कारपोरेशन हम बहुत अच्छा हमें काम करे।
Thank you, Ibrahim Bhai. Let me go back to once again Meher Haidar. So, as you rightly said, Mumbai Corporation is very rich. तो आपको कितना बजट कॉरपोरेशन में मिलता था? How much budget you used to get as a corporator, and towards health, how much you used to get? What were the decisions taken in the ward committees? Whether the community was involved, whether the PSCs functioning properly, how many PSCs functions per ward, whether as per the norms, central government norms are there, that 15,000, 20,000 population, or maybe 2 lakh population, one hospital, उस तरह का corporation मुंबई में किस तरह काम कर रहा है? Can you just highlight on that?
So you're talking about now or during COVID?
Anyway, you're not the corporator when you are there.
During COVID
Yeah.
time, yeah. So during COVID time
No, post-COVID also.
Post-COVID,
Yeah.
अच्छा. मुंबई का मतलब corporator overall budget for health this year का this time का I already said it is almost 639 point something in crores, 1,000 crore. So 11% of the overall budget is for the health, and Mumbai has many dispensaries, as I said before, but scheduled drugs is not available in Mumbai. So people, mostly the underprivileged. Mumbai, you can say it is divided into two parts, one which is very privileged one and one which is very underprivileged. But awareness is not there. Since awareness is not there, people doesn't know they are right. So even if you are rich, you have lots of money, but awareness is not there, so this whole thing is a waste. So decentralization, the 74th amendment, again I say, it is for the people, for the citizen, so that they can interact and they know their rights and they are aware, which in Mumbai they are not aware. People are not aware their rights, and they don't know how to fight for them. Yeah, corporators get fund in crores, which they try mostly to utilize in their area, like road banana, gully banana, like for water and all that, but not so much in health. Not so much in health. We can't use our fund in health. We can't use our fund to give scheduled drugs. We can't use our fund to give O2 machines. This all we can't do. It's not used for health. Yeah, but during COVID, since it was decentralized, again I say, it's due to the 74th amendment, it's a boon for us. We were able to give O2 machines because hospital beds, let it be private or let it be the BMC one, it was completely filled. There were no beds available. And since we were able to use our fund because of decentralization, O2 machines, sanitary pads, and all the other things we were able to distribute through our fund, which again, since now election is not there, but again, like before that also, our fund was never used for medicines, for medical use.
So, what are the suggestions for improvement in the UPHC or Mohalla clinic, or you are talking about small hospitals in the area, controlled by government, and any suggestions from your side for the improvement?
As a corporator, I will like to show you something through my eyes. Everybody has a different thoughts and thinking, but what I have seen, that decentralization, as you said, is not, it should not be used just a word, but it should be implemented. If it is implemented properly, I think so. And in Mumbai, if people are aware of their right, as in Kerala, there people know their rights. But in Mumbai, people are not aware of their rights. They doesn't know how to, like dispensaries are there, how to use it. Since scheduled drugs are not, they're not available. As a corporator, I would like that next time, when again this elections is there, let the corporator use their funds for the scheduled drugs. And I think so Mumbai corporation has, there is no problem of money. So, but since decentralization is not used, the scheduled drugs and all that, it is centralized, and it to be reached till the dispensaries, it takes months. Till that time the people, naturally, agar main bimar hu, I need the medicine on the spot. I can't wait 2-3 months for it. So naturally, I'll go to a private hospital. So decentralization is very important. If it is used, I think so सब चीज़ अपनी जगह पे बराबर आ जाएगी.
So with this, we have what we have come to know. ULBs, especially Mahanagara Palikas, have no power or role, especially towards the health this system. We have been only whatever the funds are available, we were just utilizing for roads and drains and lights and vagera vagera. Or health matlab only SWM Swachha Bharat Abhiyan. But here we request, it's my suggestion also, the central government to issue an SOP where it is like, every day we used to get SOP during COVID times and it has been followed. यही लेना है, यही जाना है, यहीं पर टेस्ट करवाना है. So regarding health also, I request the central government to issue an SOP so that it is followed throughout India. Now we are talking about only Kerala model. Kerala is the best, no doubt about it. But Kerala people have come forward, community participation is there, their officials are cooperating with the elected representatives. When they are elected, there is no politics there. Whereas throughout country, there is only politics. So now the Kerala model has to be implemented, means central government has to come up with some SOPs where that local bodies has to be, the local body has to be given powers for health. We request now, even in our corporation, Bangalore Mahanagara Palika spent 1,000 crores on SWM, that is solid waste management. And there is zero fund for the health. How can we expect the poor people, especially the lady who goes to household work or laborer or the rickshaw wala or the driver or the puller, we are not taking care of them. So when we start a Mohalla clinic or when we start Namma clinic, the advocate fund should be given and there should be given health card. And now there are different health cards throughout the country. Now recently one is Ayushman Bharat has come. Now state has got different health card. Labor department has got some health card. And the different department ministries have got different health cards. So I have requested in our commissioner also, where we are having Namma clinic, where you should be enrolled for the health card, which is central government is funding. Now that health card should be implemented throughout the country. It should be like Aadhaar based. If you are on now health card is for everybody as per the central government. Ayushman Bharat has got BPL card holders get 100% up to 5 lakhs for any disease, any hospitals, whereas the BPL card holders will get 75% of the fund. Now when BPL card holder and a rich man also getting a facility, the poor man is also getting facility. So why mandatory? No, make it as a with the Aadhaar card only. So Aadhaar card se aapka health ho jayega. Issue is solved. And the local clinic what we are having, that should be adequately given the medicine, the paramedicine. It should not be only the testing. As though you have an oximeter at home, you have a thermometer at home, people are looking at the BP and sugar. This is what they're functioning now. That Namma Clinic is only for the basic, testing. If you have a thyroid, if you have some diabetic, this one, if you have liver, we don't have a high-tech laboratories. That has to, again, the people go to the private diagnostic centers. So now, if you are talking about one assembly, or if you're talking about one population area, one assembly should have some hospital with diagnostic center, especially now, majority of the people are getting diabetics. We don't have dialysis centers also. Each dialysis for a poor man is costing about 1,000 rupees outside. And few people are getting thrice dialysis per week. It's very tough. Now the government should look into that. When the 15th Finance Commission report is coming, they are ready to fund. We should have one Mohalla clinic, advocate with all the X-ray or the CT scanner or with the health facility, with the specialist doctors should be in all the fields. It should not be only general surgeon. You should have a ortho, you should have a gyno, you should have a different specialist doctors where that can be. If you really think of the poor, if you really want to help the poor in the medical system, the really central government should come out with SOPs, which should be implemented from central to state to the ULBs. Thank you. Now, I will just, in the last, we have very less time. Finally, I will be asking Mr. Pandurangan Patil, sir. Sir, different corporations in Karnataka or in any of the country. There are small corporations with 30 corporators, there is bigger corporation with 243 or 200 corporators. You are with the Dharwad Corporation. So how does the your health officer supporting the public, or the public, whether public is able to, now since there is no corporators, public is able to go and meet the health officers, or the PSCs are working properly without any problem?
So, PHC or Mohalla clinic or Mohalla sanitations come under the health and other things. All systems to streamline and sustain the administration, it needs only once again local administration, local governments with a self-financial capacity. That is the only solution. Now we are thinking decentralization in the health aspect, to treat a common man, the last man, support as a health assistancy. But once again, we must think that financial structure and organization has been controlled in the center or in the state government level. How you can go for the decentralization system? It is for a day, for a month, or a year. Not constant. Not constant. It should be constant. We must be converted into the, once again, local self-government with the financial stable. Then only what you are thinking, what you are concentrating, what you are putting your ideas, what you are putting your future views, that should be materialized, only strengthening local self-government. All your ideas will be fertile. Otherwise, it will be no use. Then only think we are the fascinating, and it will be the dried. That's why anything put forward, anything go something, it has to be centralized. Only the decentralized means go into the last man. Power should be decentralized. Administration should be decentralized. Strength will be decentralized. Opinion polling surveys, then it will be strengthened. Otherwise, no use. My feelings, it is only one thing. Government, you must give the 73rd amendments with a full support. Then this decentralization system of the survey will be reached to the common man and meaningful of the decentralization. Otherwise, doubt.
Thank you, sir. Any questions from the audience? Yeah.
Yeah, so you were talking about the personal budgets and discretionary budgets, and how you cannot spend that kind of money on drugs and other medicine equipment. But what are the other forums where you discuss about health, especially, I mean, what are the kind of discussions that happen in board meetings and standing committees, and what are the other instruments that you use, whether you've, let's say, issuing notice of motion, right to ask questions, that sort of stuff. Thank you.
Yeah, nice questions. We have a ward council meeting Like in every ward, there be a meeting at least once a month. You can keep it 2, 3 also. So there especially we discuss about health, and it be a very healthy arguments where like the hospitals, municipal hospital, which is in our ward, we discuss about it, everything. Then in corporation, health issue is taken up a lot, lots of health issue. We take point of order also. Sometimes even the house is adjourned because we don't get the right answer. We don't get what we
Participants should be more important than the elected representatives. And definitely, yes, councillor is the first point of contact for the public, not the officials, not the MLA, nor the MP. So here, as you asked whether the budget is available, corporation, yes, budget is available. But see, if you ask me in BBMP, there is a health committee. But the health committee is always on the solid waste management. So that is, post-COVID only we're talking about health now. Now post-COVID only, everything is coming. So SOP also started from COVID time only. So better if we have a SOP from central government to the ULBs to strengthen the health.
Just
Thank you.
a small
I
thing
think
want to add, just a small
we
thing.
got the bell.
Like about the awareness during COVID, people were so scared कि अगर उनको एक खांसी भी आती थी, they used to check. But before COVID, polio dose, the BMC workers go door to door for polio dose, लेकिन कोई polio dose लगाने के लिए राजी नहीं होता है जल्दी. Because they are scared, अरे पता नहीं polio dose ही है क्या, या injection लगा के हमारे बच्चों को कुछ कर देंगे. But people should be aware, especially in Mumbai, there is no awareness. This is what I wanted to say.
Thank you very much. Please remain here. May I request Mr. Sunil Nandaraj, advisor to HSTP, to please come up and present mementos to our speakers and to our chair. To our chair, Mr. Abdul Wajid. To Dr. Pandurang Patil. To Mayor Heather. And to Mr. Ibrahim Babu. A group photograph. Ladies and gentlemen, lunch is now ready. Half an hour only for lunch, because we've got a very special session that follows lunch, where we're going to ask all of you to put in and contribute your concerns, your views. So it's going to be an interactive session. So half an hour for lunch. We hope to begin by about 2:30. Thank you. Did you change it?
होगी बात चीकू भाई से बसोड़े में फोन नहीं उठाता कह रहा मैं यहाँ पे गाली खाने के लिए आऊंगा क्या एक घंटा रुकना चाहिए, खा गए तो
Check, check, check. Ladies and gentlemen, please finish with lunch and come to your tables. We've got just one more session left. And this is the most interesting session. So I urge you to please return to your seats now. And we promise that we won't put you to sleep. Requesting all the participants who finished with lunch to please return to their tables. We're almost at the end of the two-day conference. May I request you to please take your seats. Those who are still at lunch, you've got about 5 minutes to quickly finish and join all of us now for the last session. All those who are getting comfortable at the rear of the hall, we're going to be asking you to move from the rear to the front. We do not want anybody as backbenchers today. So everybody who's sitting at the back, please move forward. We want you to fill the seats in front now. All those on those chairs, please move and fill the tables. Please move forward. We're going to take those chairs away, so please move forward. जो भी कुर्सी पे बैठे हुए हैं पीछे, आप लोग आगे आइए. No, I'm not singing tonight. जो भी कुर्सी पे बैठे हुए हैं पीछे की तरफ आगे आके बैठ जाइए. कुर्सियों को हम हटाने वाले हैं, आप टेबलों के पास आके बैठिए. Please come to the front. Those who are seated on the chairs, we're removing the chairs. Please come forward and take your place at the tables. We've got plenty of room, so please come forward. Come on. Mr. Guha, I'd like to request you to please ask the group that is next to you to please move out. Come forward. Navdeep ji, please aage aaiye. Aage aaiye. You've been smiling right through, listening to me, but you're not wanting to move. No backbenchers today. Everybody come forward. Delegates, please be seated. The longer you take to be seated, the longer we're going to hold you in the hall. So you're not going to be able to do any Delhi darshan then. No shopping today. Please come forward. Please come forward. We're making it interactive. This session is going to be completely interactive. So come forward. There's lots of place here at the tables in front. Ladies and gentlemen, we're at the concluding session now. And this session is to present the recommendations and advocacy objectives. I'd like to invite all our speakers up here on to the dais. Mr. Rajiv Sadanandan, the CEO of HSTP, the CEO of Janagra, Mr. Vishwanathan, the chairperson of HAP, Dr. V. Raman Kuti, and as chair for this session, I'd like to invite the former Chief Secretary, Government of Kerala, Mr. S.M. Vijayanand. So, ladies and gentlemen, we've been telling you since yesterday that this session, although we are going to be sharing the advocacy objectives as well as the recommendations, we're also going to ask you to share your concerns or flag any things that you would like to be discussed or mentioned or highlighted. This is your chance to be able to share whatever it is that you want our officials to be aware of. So I'd like to now just hand over to the chair. We're going to do this a little differently. Just be aware that you may be called upon to speak or interact in this session. Mr. Vijayanand, sir.
Start the final session. Initially, for a few minutes, you can all give your suggestions on the way forward. Not necessarily questions or comments. Yeah, questions also we can answer if you have not covered. But basically, the focus should be on the way forward. Because normally, all conferences end up and then it's not followed. But this time, there is some intention that at least the three big players, HAP, HSTP, and Janagraha, want to take it forward. So, your suggestions on the way forward, or even questions or comments for next 20 minutes? Yeah, still is over. But yeah, 20, 30 minutes you can, this thing, then there will be other kind of things. So anybody can open up or start.
Okay, Srikanth just issued a threat that if you don't ask, we'll ask you questions. Yeah.
Is it okay now? Oh, okay. So we all know that there is this 15th Finance Commission grants that are to be implemented through the urban local bodies as well as the Gram Panchayats at the village level. So, and we also know that there is not a lot of capacity among these urban local bodies as how to go to implement these grants. And these are very huge in terms of the establishing the urban health and wellness centers in the urban areas and same in the rural areas. So we can begin with building the capacities of urban local bodies as well as the rural local bodies, the existing ones, so that we can start utilizing these grants through them and move forward. And Meghalaya state, they don't have urban local bodies or rural local bodies as such in their entire state. So the health department came up with establishing their own, at the village level, separate committees for implementation of these grants. And they are giving powers and funds to the district, and through these they are trying to implement this. So this is another one aspect which we can think of moving in the states. So that's what my take on.
Other suggestions?
Dr. Keskar, if you can respond with your experience. Dr. Keskar has been in a leadership position in the health department of BMC. Any inputs, comments from you on the conversations?
I did not get what question he posed. Okay, general. Okay. In general, this I'll congratulate all the three leaders and the chair to they have arranged this conference because this topic is very important, and I really agree that decentralization will lead to community engagement. But in spite of that, there are many points raised. Some of them are positive, some of them are negative also. Like community engagement, to me, I'll divide it into three parts. So when it comes to decentralization, one is need assessment, one is execution, and then in the last panel we discussed about finance and how much is the budget. Again, to me, need assessment needs to be decentralized because the local people will know the needs more, and this should not be, public health is the topic which should not be related to politics at all. It should be general, whatever is the need it should be given, and if it is decentralized, good. Then for execution, certain central control needs to be there, because all the decentralized people or at the root level, people may not know the rules or may execute in different ways also. So there has to be some kind of guidelines. Either they can be given to the ground level authorities and then executed, but there has to be some kind of control. And regarding budget, I have got different opinion. I feel even though at large we compare how much budget is utilized and how much it is successful. So, but as far as promotive health is concerned, budget and promotive health do not go hand in hand. Vijay Anand sir said that he is working for last 20 years for decentralization, but it will show little result now. So his efforts and budget, his efforts and impact will not tally. When you go think of promotive health, if you immunize a single child, will not protect from polio. But when you immunize all the children, then you go for polio eradication. But when you deliver a single child in a maternity home, you feel yes, you have done successful. So promotive health requires a lot of effort, so it should not be compared directly with the, it will require immunization of all. So same way, behavioral change will also require policy of all. So this requires a lot of budget, and it is not seen immediately. Whereas, and budget, when it is used, if it is used in bigger, say, construction sites or bigger production or machinery, it is used more. But that doesn't mean that it is work for the health. When it is promotive health, it requires a lot of effort on behavioral policy and also on the other execution policies. And especially the salary component is taken as establishment. So it is not taken really for health. So that's why budget and this, public health should not be compared directly. That is my feeling. And another thing, if I can respond to Meher Madam's earlier issue, if time permits, I can. She was saying about no medicine in the dispensaries, etc. I discussed with her also. Again, there are two different points. One is the procedure. Procedures are there, and because of the procedure, you may not find the actual medicine at the time. But if you decentralize, then also it will have certain impact. I'll give you example. If say tertiary institution, AIMS or KEM will need say 1,000, any medicine in 1,000, but the dispensary will need only one. So dispensary will not get that much attention even from the production company also, because they will not deliver one, they will try to deliver 1,000 to bigger company. So when it comes to decentralization, That is the issue, and the policy and the rules, that is also very important. And if anybody wants to help out of pocket, then that is different, because then there are, you just need the right kind of medicine needed for that dispensary. But that can be done out of pocket expenditure like that. These are my some of the views, and I feel that decentralization should be done in these three different ways, and guidelines should be given to the ground level people so that they can utilize. That is my view. That's it.
Thank you. I've listed some list of things based on some of the struggles, some of the experiences, and some of what I heard. I could not attend yesterday, but Anagha's summary was helpful to understand that. So one is about the financing part, the kind of advocacy that is needed. In the sanitation sector, I have been advocating for this for long, and I think in the health sector also it is important that in a federal system of multiple tiers, the GST share is only going to the national government and the state government. What happens to the other tiers? So how can a city or a town or a Gram Panchayat get a proper share of the GST for the products that has been told or whatever sold in their constituencies? It's a question that would definitely help them to get some kind of revenue, additional revenue, because currently, like the national GST distribution to the states have their own issues, and the state level distribution of revenue to towns and panchayats are also having their own issue. So we need to think about that part. That is one thing that I thought about financing, one added layer that could be considered. The second thing is about having an institutional arrangement for urban health training, capacity building. We have, several spread institutions, maybe All India Institute of Local Self-Governance, various institutions are there, but within the NHW or within the similar kinds of training institutions, we really don't have anything to train people's representatives, health officials, or related people of the urban, larger, either human resources or elected representatives, something that we need to consider nationally, and that could be something, maybe a future advocacy point. And the other thing is for having a requirement of human resources for health in the urban areas. Even in the National Urban Health Mission, while the recommendations were being finalized, formulated, one of the issue was that we could not really define what can be the basic human resource infrastructure that could be provided for the. So we added some health and wellness center, but we don't know whether it will be at ward level, what kind of level it will function. And this population norm, we need to bit scrap. We need to go with the urban governance infrastructure. So it should be something at the ward level, something at the corporation level, whatever. So we need to do something in relation to accountability of the people representatives as well. So that is something, a human resource infrastructure mapping for urban area. And then the understanding about the urban, term, also the area, the diversity of the term and both the urban area, wherein, we have one single measure for talking about Mumbai, Brihad Nagarpalike, or Delhi, or Calcutta, or Chennai, and we speak in the same tune and sound for Bhopal or Raipur or similar smaller towns. So we need to really think about the larger corporations, larger towns, larger cities, and then go into small and medium towns separately, small towns and medium towns, also adding census towns. This part, quite often, we are not looking at census towns, which is the growing town from the panchayat situation. And that is, we have a program called Shyama Prasad Mukherjee, urban program, they call it, rural-urban mix kind of, but I don't know what kind of attention it is giving for the health and related issues. So we need to really look at these different levels of urban and also different, segments within urban. Specifically, I think we need to frame a health rights framework for poor, homeless workers in the urban areas. That is totally missing. And unless we make that framework for the poor, for the homeless, for the workers, informal workers within the urban segment, it is going to be a major kind of gap, because we don't know who is accountable for people in slums. We don't know who is accountable for, even though we have initiatives like Mohalla clinics and all that, it is about people coming to those facilities and whether, these workers are having convenience, whether they're working on something, some issues and all that. We don't know. We are not based on, somewhere, there was a talk about what you call compassionate governance. So we need to be compassionate about the urban poor segment, which is one of the very important issues. And then how to bring private regulation into urban bodies, some ambit of urban bodies is something. I don't know how much we can bring within the Clinical Establishment Acts or related issues, but how to bring it, at least to mention it, so that from ward councillors to chairpersons or standing committees to the chairpersons or mayors of the urban local bodies, or the Nagar Panchayats or municipalities or whatever, how they can talk about, how they can intervene into some of the services provided by the private sector, and many of the problems that are therein is an issue that we need to look at. And then about the monitoring structure. Monitoring, and so how can you build in a monitoring and evaluation framework that starts from the household level to ward level to maybe neighborhood level and ward level. That kind of a structure is something that totally we don't have a proper monitoring framework for urban health. So that is something. So from the urban health resource centers work in Indore, I think they have tried to start something, maybe to look at from that. And then finally, I am in a process of writing a practical insight for urban health, based on what is currently available, because major constitutional changes and major financial provisions are, we can demand for it, but we are not expecting it in the very near future. So within the available policy environment, within the available political environment, and within the available human infrastructure, what are the things that can be done, initiated by the corporations, municipalities, and small town governments, is something that I am preparing. I'm sure that this workshop is also giving me a lot of insights towards that. And maybe I'm happy to help HSTP, Janagraha, whosoever, to help in that training process to develop a practical kind of framework for that. Thank you so much.
Dr. Srivastav from NHSRC. Dr. Srivastav, your comments and inputs. Thanks to NHSRC for their very active and broad-based participation.
Hello, good afternoon everyone. I am Dr. Smita Srivastav, Senior Consultant from Public Health Administration Division of NHSRC. So we are thankful to all the organizers to be part of this meeting and to be part of the wonderful deliberations regarding the decentralization and the dissemination of the two studies which have been carried out. So at the outset, I would like to say that this decentralization is a very important topic as far as NHM is also concerned, and both from the rural as well as the urban point of view. And one important thing is that, and the district health action plan and the city health action plan, they were always a part of the NHM framework, although they could not be uniformly carried out at the national level, uniformly across all the states. And another important thing, like we have heard the deliberations also. So right now, after 10 years of NUHM, the NUHM framework is in the process of revision. So what most of the deliberations which happened over here and the recommendations or the suggestions, inputs from the various experts, mainly on those lines itself, the framework is being revised, where we are recognizing the importance of convergence, which should start from the national level, and various platforms for institutional mechanism, which will involve the urban local bodies as well as the ward level committees. They are also being made part of this. And besides this, the roles and responsibilities of the ULBs, which need to be defined, and some sort of structure, the uniform structure for the urban local bodies, that is also being thought of, and will also be coordinating along with the MOHFW with the Ministry of Housing and Urban Affairs.
So it is almost in the later stages, and national consultations have been held with public health experts and the urban health experts also, the municipal corporations, as well as with development partners. So, so we have taken note of all the positive inputs which have been discussed over here. Thank you.
Yeah, this one is working. So we heard from a couple of people about guidelines from the center or SOPs from the center. Now, on one hand, we are talking decentralization, but I also understand that, yes, you can't decentralize everything. So in a way, these two are contradictory. At the same time, how much do you decentralize, at what level, and what all should be decentralized? And there are no easy answers, I know, of course, it only comes from experience and when you implement and you learn. But these are some of the things that we might need to think when we talk of decentralization. And obviously, not everything will work in the same manner in different places. So whether guidelines from centers, SOPs, or from the state to the districts, or should the district be allowed to plan it on its own, or the panchayat should be allowed to plan on its own. So, because even in Professor Dina's presentation yesterday, even the international experiences varied around this. So that is something I wanted to highlight. In the urban areas, maybe I've missed what I haven't heard is about involvement of people in the cities in the whole decentralization process. While we are talking of urban local bodies, the citizens who are there, what is their level of involvement? Not only the poor, but also the middle class who seemingly have more voice. Are they involved in this process? And the third is about the informal providers, which are a whole lot especially in the cities. So how do we address that? That has been a concern forever. When we talk of decentralization, is there something that we can work around that? Thank you.
Hello, am I audible? So after the discussions and deliberations that were happening in decentralization, there were few points which I noted down I wanted to highlight, maybe we can look into. So first one is the autonomy for the urban local bodies in terms of planning and allocation for healthcare. The second is maybe, as ma'am has also mentioned, that the involvement of people in planning process in the city and is not that much. So maybe we can try to identify ways in which we can inform the people, because most of the time maybe the knowledge and the information about what's happening and what are the services and also what entitlements they have in terms of engaging with the government or engaging with the governance level. So maybe we can try to identify ways. Also maybe we can utilize digital platforms through which we can inform the people about what the urban local bodies are, what all activities they are doing and maybe they are planning. And also one more point is, as sir has mentioned yesterday in terms of urban clusters, so when urbanization is happening, it's not very happening in terms of one municipal corporation or maybe one city. It's happening where one, like for example, Mumbai municipal corporation is developing, and surrounding there are other corporations also, which may not have the capacity as Mumbai in terms of delivering services, but there are people who go from maybe Virar or maybe other corporations and utilize the services in Mumbai. So maybe while we are considering, we should look in terms of the cluster model in empowering or maybe using the capacities of the urban local bodies to deliver services. And also one more point is maybe we should have strong grievance redressal models where people, when they say that there are services, if they try to understand what are the services that are provided also, and if they have complaints, then there should be a grievance model where people can highlight those grievances which can be looked after. Okay, thank you.
I just use this opportunity to, it's not, hello, yeah. So I just thought I didn't want to speak because decentralization done some work, but I thought I'll just share some of my thoughts based on yesterday's and today's. I think first of all, it's important that we look at decentralization critically. Has it really worked? What has happened? I think that is one research topic or area of concern or investigation that needs to be done, is how really effective has decentralization been. And I'm not talking about Kerala, please. Second, I think we need to go beyond panchayat, municipal corporation, municipalities, and municipal councils. Let's talk about decentralization at the central government, to the state, that entire flow, because decentralization is much more than panchayats and, because right now when I brought up that point about now the discussion or the debate, whatever little in the small circle of health people we have is on whether health should be a state subject or it should move to concurrent or whatever, So I think let's go beyond this and go to look at these issues. Another point is, what functions can be decentralized and what cannot be? Like I and Tarun, we keep fighting over this issue. I mean, decentralization is good, but some of the things about better centralized procurement, for example, has to be centralized because I get the best scales for whatever I order. I mean, let's look at what is good in terms of centralization and decentralization in terms of policy, functions, delivery of services. I think you can look at research, documentation, capacity building, implementation. One of the things I think is the entire COVID documentation. How did the decentralization help or did not help? What were the state responses? And many of the states did really well. I know Bombay Municipal Corporation because I worked during that period with the BMC and I looked at how they did in Dharavi, and it did a fantastic job, in that way. So I think another aspect is how decentralization and NHM, because NHM is highly centralized. The guys sitting in Nirman Bhavan keep out giving every weekly guidelines and adesh from there on what to do and how to do, what curtains to buy. NHM was supposed to be decentralized. So let's look at NHM and the entire thing of decentralization, because for me decentralization would be the day when the panchayats are able to recruit their doctors and nurses and fire them also. That would be decentralization for me. Not telling them, oh, do vaccination and all those things. One of the things that lady brought up is very correct is provision and information. I really don't know what healthcare facilities are available in Bombay city. Madam was telling about people do not come, when I go to my tertiary care hospitals, I start getting lost right from the gate. What services are available, we really don't know. Where are the dispensaries? Where are the maternity homes? Can we just do a simple thing is what I keep bringing this in every place. I attend very few conferences. We have an app for Zomato, pizza, everything, but we don't have a simple app for healthcare facilities in our many places. Why can't I have an app to know where to go for a blood test or where to go for a maternity, simple things like this. We talk about technology and last point I would just, I'm trying to work on it for many months. Simple thing is working with the government or not working with the government. Many people don't know who is the government. The bureaucrat will say, I'm not the government, he's an elected guy. Elected person will say bureaucrat. And how does the government function? It's an opaque thing. Frankly, how does a file movement take place? You go and talk to the Mantri ji, what happens? How does the government function? I think this is one thing local governments need to know. When you are talking, a panchayat person goes to Trivandrum to the Secretariat's office. I mean, you can get lost among all those files. I mean, I think we'll have to really look at that. Thanks, yeah.
Just wanted to make two observations actually. I think COVID really brought out the whole issue of surveillance data and the importance of data. And I think while on one hand we have polio and we've had some very rich lessons, we also talk about IHIP and moving towards that, but I think we've not really looked at surveillance systems and data in metropolitan systems. We're still using the old models of HMIS and trying, I don't know what we're trying to do, but I think that's an area that needs work, and I do understand that the Health Infrastructure Mission is looking at it, but I think there's a long way to go. So one is that, and the other is the point about community surveillance. We're talking about communities, and there are some varied experiences across different states. Kerala much further down the road than others, but how do we really harness community surveillance? And I think COVID, whether it's Nipah, COVID, I think these are lessons, and looking at the rate at which pandemics are recurring, it's far more sooner. So whether it's not just pandemics, but even disease outbreaks. So how do we really look at community surveillance systems? Can we look at some innovative models for that? And also look at urban, metropolitan-based systems, which are not maybe, they kind of fall in between the cracks between NHM or rural, urban, whatever nomenclatures of programs we may want to use. Thank you.
Good afternoon to all. I'm Dr. Devjit. I'm from Regional Resource Center for Northeastern States. This is a branch of NCCRC over in the Northeast in Guwahati. So basically, we represent all the 8 Northeastern states. Sir, the point is role of decentralization and all those things. We just learned a lot, and thanks for being a part of this workshop. Sir, as we saw all those models like yesterday in those cities and all those things, what you can do is that in 3 or 4 states over in the Northeast, they already have a completely village council system. There is already a kind of totally a decentralized model. Under 15 FC also they are distributing those funds through 15 FC. Moreover, Nagaland already have a communitization act. So maybe in those communitization act, whether it is being implemented fully or not, what are the pros and cons of those communitization act, because it was implemented more than 10 to 15 years ago. And as some speaker mentioned it, just maybe previous speakers, so maybe the system, decentralized system, like all the kind of village councils members are going to control the government staff and the contractual staff at this in that area. That may be you can see it not in 100%, maybe in 10 to 15% of the village councils you can see that. So maybe if you can add it compared to going ahead with a kind of one single model, if you add different kind of models and kind of coming up with a mixed model kind of thing, so that I think that will be more successful compared to going ahead with only one model. Thank you.
So, good afternoon, I'm Navdeep Gautam. I was a part of the study which Janagra has conducted. So my observations are basically more broadly on the urban systems. So still, after so many years of independence, we are still thinking that we are a rural nation, and we are having all the focus on the rural areas. So my comment may be weird, because we are a bureaucratic, centralized to decentralized system. But as far as the urban is concerned, I don't see any centralization or decentralization. For example, we are having Department of Panchayati Raj and Department of Rural Development. There is no such body of Department of Local Government which look into directly supporting the urban local bodies. Some states have the Department of Local Government separately and Housing and Urban Development separately. But Housing and Urban Development is more centralized for housing and other urban development schemes, not supporting the local governments. Then second issue is that the parasitical bodies which we are creating in the urban areas, for example, within the urban space, we are having different improvement trust and the urban development trust, and then we are having urban development authority, greater Falan development authority, which are actually, it's a having decentralized centralization of the things. So this is one regarding overall urban systems. And secondly, regarding National Health, Rural Health Mission. In 2005, when this NRHM was launched, After that, I was among the first district program managers who joined Rajasthan, and then around 15 years I worked with the National Health Mission in different capacities. Issue is this, that the National Rural Health Mission original document gives a beautiful things about the community participation and decentralization of the services. And in the beginning years, if I have to talk, that Tarun Sim sir was director at that time, we were contesting our PIPs, there was a liberty to the states to look into the things, especially when this, the transition from RCH to the overall health system was there. But even states doesn't want, or I don't think they don't have the capacity to adapt the guideline. They want to adopt the guidelines of the central system rather than adapting it. In 2 or 3 states where I have worked, we have adapted the guidelines, because we can't see that the Kerala cannot be compared with Punjab, Punjab cannot be compared with the Bihar. So the important thing which when we were conducting this study or we were visiting the fields, the important thing is that it is not only the population, it is not only the territory, but it is also the capacities and the political as well as the bureaucratic will that needs to be looked into overall urban scenario. So these are.
Any of our political representatives, elected representatives, any comments, inputs?
Hi. Good afternoon, everyone. I'm Jatin, work with Path. Okay, sorry. Jatin, work with Path. Just a small submission. Thank you so much, first of all, for all the insights which came out to be in the last 2 days. Just a next step from my side. Just a humble submission in terms of synthesizing all these learnings and come up with a menu of options for all the tier type of cities, tier 1, tier 2, tier 3 cities, wherein we can have a measure of success wherein we can call the decentralization as a success or not. And then building those models or breaking those models into various things related to enhancing the capacities of urban local bodies or local self-governance and monitoring or enhancing their planning capacities and everything. So the next step from my side for this workshop can be a menu of options which can be adapted or adopted or customized based on the local context of the municipal corporation, municipality, and lower tier 2, tier 3 cities. Thank you.
Since there are a lot of very competent and learned organizations present in the room, I think it would be a lost opportunity if I do not say what I've been thinking about for a long time. Recall COVID. A lot of people in Delhi, Mumbai, all the megapolis, all the glittering megapolis rushed back to their villages. Why did they rush back? Why did they come to the city? They came to the city looking for a better life, more security, less anxiety. They came for all of this, and the moment COVID happened, all of that was wiped out. In order to ensure that the same thing doesn't happen, and there is a sort of an insurance against health event related anxiety for people who are in cities, all the learned organizations over here, can they consider setting up a permanent think tank about provisioning of basic healthcare services, preventive, promotive, as well as curative, perhaps first curative and preventive promotive in all the cities? Now this plan will coexist with the agenda of decentralization, but it doesn't have to be wrapped within the packet of decentralization, because decentralization is going to take time. It is something which is power sharing. People are not going to easily do it. It is going to take time. As a first step or as a separate step, can we have a twin initiative of provisioning of services aimed at eliminating health event related anxiety of urban population? I'm not talking about slum dwellers, urban population. Even rich people in Delhi faced huge problems during COVID. And for the first time, they had to visit government hospitals and they figured out hospitals are so dirty. Hospitals were always dirty. It's the rich figured it out for the first time. And for the purpose of ensuring that they don't figure it every time an event happens, can we set up a secretariat that actually looks at provisioning of healthcare services in urban areas on a consistent peacetime basis? Peacetime. I'm not talking about COVID preparation, but peacetime, whether the hospital quality or private or preventive promotive services in private at primary level can be improved. Why this would be so easy is that the biggest problem of healthcare HR is not a problem mostly in urban areas. Logistics is not a problem in urban areas. Communication is not a problem in urban areas. So whatever has been inhibiting us in rural areas doesn't exist in urban areas. So there is really no reason why we shouldn't be able to do it in at least Delhi, Mumbai, Kolkata, Madras, Bangalore, cities with more than 10 lakh population. And there are lots of them. So if the organizations which are represented here can apply their mind to it, and if they find it appropriate, put up an institution for this effect. Thank you so much.
Hello everyone, I am Guru Sravanan from Institute of Grassroots Governance. So basically I just want to point out, in the planning process at the grassroots level, are we ensuring the marginalized voices? That should be there. Like I have attended a lot of Gram Sabhas and then district health assemblies. So it is actually mandatory to ensure these marginalized youth, women who are participating in these forums. So I believe decentralization is nothing but ensuring social justice. So in this manner, another thing is that the accessibility, the factor of accessibility, whether the health centers or whatever it is, whether it is youth friendly or not. The other day, like if I go to a particular hospital and trying to get this ECPs, emergency contraceptive pills, it is not available. And the doctors are also not willing to distribute that. So these sort of like the health practitioners or the doctors who are all misogynistic also. So they also need some sort of training programs. And as well as if you see these elected representatives, they also need training on sexual and reproductive health rights, also on mental health. So these things should be there. So yeah, these are my comments. Thank you.
Another point came to my mind is each ULB should be self-sufficient idea. Many cases to Mumbai because there are no services available over there. So for that, if some kind of referral audit system is there, that would be better. And Clinical Establishment Act, if it comes, it would again help. Because when we talk of especially health service delivery, doctor per population, etc., we do not count private doctors, private service deliveries. Or so if that can also be counted, or how can we take that account, that would be easier.
Rini is not there. How many minutes, I should ask? How many minutes?
Before she comes back, finish what you decide. Rini is not here. Just go ahead.
Friends, not summing up nothing. some suggestions on the way forward, and I've been benefited immensely from whatever you said. So I'll give some macro kind of things, and my colleagues, fellow panelists will supplement with crisp points. First important thing which came up is we have to assess what happened during COVID. Not from the epidemiological point of view, how we managed, how local governments came together, how rural worked, even where rural doesn't work otherwise, how SHGs worked with panchayats, how government trusted panchayats. So that is a big document, analyze, disseminate, and as was mentioned, critically assess, did we really succeed or it was just a kind of thing. That's a big lesson. We need to take it forward. And before that, it came out beautifully, the definition of decentralization without community engagement is not decentralization. So when People's Plan was launched, we told everybody, it's not power to the panchayats, it's power to the people through the panchayats. So I think I was very happy that everybody endorsed that view. It will not stop at the panchayat, it will go down to the community. And as was mentioned, the poorest of the community, the most marginalized, what is called social justice or inclusion. I'm very disappointed with what has been happening in the use of FFC grants, including in Kerala, where hospitals are directly under the Panchayat Raj local governments. Somehow it's been centralized. So, as somebody mentioned, we need, I don't know how much we can influence Government of India ministries, a methodology developed for use of FFCs by Gram Panchayats, by intermediate panchayats in some places, and by urban local governments, for whatever it's worth. So this is how it should be used. Some methodology, it can vary across states according to the level of decentralization. Then what are the new opportunities which are emerging for whatever we are discussing? One, of course, I was very happy to hear that NHM is doing a kind of a review, but it looks it's too late to intervene. But this FFC thing should go into the NHM. Unfortunately, NHM everywhere, including Kerala, is highly centralized. So even the district projects are very mechanically prepared, and it goes up, and ultimately the project sanctioning committee. I have sat as chairperson of so much project sanctioning committees in Ministry of Rural Development. I know how it is handled. So at least let NHM, both the urban and rural, consult the local governments. You don't have to do anything. Just a consultation alone should be mandated if it's too late for big changes, but I think a lot of opportunities present. Then, something which we didn't discuss, I know because I'm working with Ministry of Panchayat Raj on that, they are now coming out in a big way. Urban, it has not started. Localizing SDGs. So we have another 7 years of SDG, and that, how much traction, I don't know, but states are responding well. And that has a lot of opportunities because health is an important SDG, and a lot of other SDGs will influence health. So I think we need to look at that. And then the next step, only few states can do it at that time. Again, it's having a lot of traction. Communitizing SDGs. Of course, for want of time, I cannot explain the concept. Getting the community, particularly the SDGs, into understanding SDGs at least. That will improve demand. And in all this, that has been mentioned several times, the role of the SHG. One, the last mile connectivity with people and reverse connectivity to government is very, very useful. And as I told you, there are 80 lakh SHGs. Urban SHGs are very slowly developing. Only a few states have it. And if you want these kind of things, a beautiful idea came. I fully support it. Health rights and a citizens' health charter. What we can give, not vague promises, is very, very important. Then comes an idea which was discussed. I'm just summing it up. The so-called multi-level planning of health. You can't slice things into compartments. It keeps flowing without infringing on our autonomy. Even WHO came in a big way in health planning during COVID. So it's not that you do it locally or nationally or subnationally. So there is a, for which that came out very well. Who does what has to be carefully documented, carefully written down. What is called responsibility mapping and what should be the local planning process for health. Some may be done by the health department, but some may be done by the local governments, but some kind of a common planning process. I was very actively involved in the consultation processes of NUHM and little bit on NRHM. And at that time, they promised that there will be local planning for health, community-based planning for health, which was discussed in great detail, and there were even manuals for the rural areas. It didn't work. We need to revive that. And what can local governments do? We need to tell them, and I call it low cost, no cost activities. Very much what you mentioned, madam, that you don't need money, or many of the things are lying around. Yeah, so you just have to demand access kind of thing. So the Gram Panchayats have a role in creating demand and facilitating access. Decentralization varies across the country, hugely varies across the country. And states which were together also different. Telangana and Andhra are different. Chhattisgarh and Madhya Pradesh are different. So we need to get into what I call as is, where is decentralization. As was mentioned, it's political. I don't think any one of us can really influence any government at any level in decentralizing more. But there is, actually I've studied decentralization in I'm not mentioning the states where we don't think decentralization exists. But when you look at the government orders issued, there is decentralization. Much position power of local governments, inherited over generations. So within that, you can do this. That should be the starting point. As was mentioned yesterday by Dr. Thomas Isaac, you have a minimalist plan within this framework of as is, where is. This state, so much decentralization is there. This is how we develop it. And I must tell you from my experience, I have developed, it's not a theory, as like the 9F is not a theory. Okay, I forgot to tell you the 9th F, that was future. Decentralization is not static. You move ahead unless you have a vision of what you're going to do next year, after 5 years, 15 years, it's not decentralization. Okay. Now, it's called rule of 1/3. I checked up with all the state governments in rural when I was in Delhi. Rule of 1/3 means 1/3 the local governments are good, 1/3 are average, and 1/3 are below average. 1/3 of the top 1/3 will beat the best collector. 1/3 of the bottom 1/3 will beat the worst state in the country, in the world. So that's a range. But if you work with the top 1/3, a lot of things can happen. Where my request to, and I'll also mention that I'm not shirking responsibility. What is called nurturing beacons. Kerala's People's Plan came from nurturing of one Gram Panchayat, developing a methodology. NRLM came up by nurturing clusters. So it's doable, which becomes schools of practice. We need activists to mentor them. Whoever, for whatever worth it is. And the Panchayat should be willing, not the state government. You can work with them. And an excellent model I saw during COVID, RCRC, somebody would have Rapid Coalition for Response to COVID. Some outstanding NGOs came together. They did phenomenal work in the most backward parts. So the idea is to set off a virtuous circle. Panchayats are too bad, they are corrupt, they eat up money, or local governments are inefficient. Try working on few beacons. I think there are enough persons here, and NHSRC can also play a role. Somebody mentioned, I strongly disagree, that during COVID, I think somebody from UP said, because of votes, they worked well. No. If you trust a local government, they will work well. During COVID, they were trusted. They were given powers. And the government believed that they will do. That's psychological. And they delivered. So I call it soft devolution. We don't trust local governments. Trust them and they will deliver. That's the big lesson. So let me conclude. Do you know how all of you know how modern local governments came about? Just for public health. Out of the Industrial Revolution, London cannot decide. Ultimately, you have to decide. And people have to decide, not officials. So it's democratic decentralization. That was the origin. So let us reconnect to the original thing. That's a natural function, a traditional function. Somebody hinted it today. I'll re-quote Dr. Jacob John, who writes fantastically. What the West achieved through water supply and sanitation, we are trying to do through antibiotics. So local governments are required for doing the, what do you call primordial, you taught me yesterday, primordial and preventive kind of thing. So localization of public health is not an option. That seems to be probably the only way. There could be other ways. The last point on which a lot of responsibility I want to cast on every organization here, what is called action research, building of beacons. And there we have a lot of points for which some kind of a loose coalition. We don't have to form a network of persons here sharing, exchanging, and we may achieve success in certain parts. Then, since I am not shirking my duty, I have convinced the panchayat presidents who have come from Kerala to develop a Pakka health plan as it should ideally be done. And I have offered my services to them to enable them to develop it. All the presidents who are here have very happily agreed. So I'm sure we need to spread it to other states. Thank you. Now I request my fellow panelists to fill the gaps and add.
I think after that there is not much to be said, but I see decentralization as a choice, as a policy choice, which we have made by the 73rd, 74th Amendment. And of course, this choice opens up opportunities in all areas of development, including health. And as Mr. Vijayanand said, public health is the primary function of most, that is the idea of the local body. That is the public health movement in UK and USA. If you read the history, that is what started the involvement of local governments in health. So, which is very apt that we should continue this. But as I'm just responding to some of the points raised, as my friend Sunil said in the morning, not now, but he said there is a huge centralizing tendency here now in our country, which is quite right. That's also a choice. They have the political choice right now seems to be at the national level to centralize everything, and they are going about it, and that's another story. So we have this conflict all along. You can't. I think if you read the history of all the countries, you will find that this has been there, in the tension between local governments and the central government is going on, whether to give more autonomy, whether to give less autonomy. So all those will be there. That will be in the background. But I think as professionals, public health people, given that we have a decentralized setup, at least in our state, that is how I respond to it. How best can we make use of this opportunity? And that is what we have been looking at, what has happened over the 25 years and what can we do moving forward. So we have plans to go from here, from whatever we have learned from this exercise, to choose certain themes, like we have found that urban health is a weak area, tribal health is a weak area. In spite of all the good things about Kerala being said, these are areas where Kerala lags behind. So we need to sit together and maybe brainstorm about how do we, within the framework of decentralization, improve and move forward in these particular areas. And I think a lot of ideas have to come from the young people. We plan to do that, and maybe we will try to push the local governments into some of these areas. That is, as activists and advocacy people, that's what all we can do. And rightly, as was pointed out earlier, in the urban space, urban area, somebody spoke about the tension, the stress of the people when calamity strikes, which is very true. And it's partly because there is no system. So everything breaks down and people don't know what to do. So that is why we have always been advocating that we should develop primary health care for the cities. We have hugely forgotten this. We have focused on the villages Even there, of course, we are nowhere near perfect, but at least there is something on paper that you have the PHC, the sub-center, the CHC. There is a system, and if you can fill in all those slots and they all function properly, we'll have some semblance of order. But in the urban space, it is not there, except maybe perhaps in some big cities like Mumbai, where traditionally the corporation has been very strong, and they do have money, and they are running hospitals, even medical colleges, so they can invest in. But in most small cities in India, you don't have any system, and that is what. So we strongly advocate for a strong primary healthcare system within the cities and the towns, which will be in place, and each family, each person should have some access. Maybe we can adopt models from other countries, like where we have registered practitioners, or we have to register at certain PHCs or local centers so that you have a first call. Whatever goes wrong, you have some system to fall back on, and they will advise you, or they will take the necessary act. That is what ideally it should be. But of course, it's a long way to go, and we need a lot of investment also. So these are the things that we should be thinking about. I think these are some of the responses that I felt hearing the feedback from you. Thank you.
Thank you, Mr. Vijayanand. Like I said in my opening remarks yesterday, we are the new kids on the block, or we are the babes in the wood. We are very new to public health and primary health care. But we are very keen to learn. So thank you to HSTP and HAP for giving us this opportunity to get involved in this workshop and the studies. I'll share a few thoughts on systems change in cities. I think we have to get over the obsession with outcomes and outputs. Even as it's important to measure outcomes and outputs, we have to invest in strong systems and institutions. And systems and institutions are inputs and processes of governance. Unless we have strong inputs and processes, you will not get the desired outputs and outcomes. Unless you have strong systems and institutions of governance, you will not get improved service delivery. I think in India, as a democracy, we sometimes get ahead of ourselves, get impatient to achieve great outputs and outcomes through short-term measures without doing what it takes to invest in inputs and processes or systems and institutions of governance. That's particularly the case with respect to urban governance as well. The city is a system of systems. In the city, public health happens, water and sanitation happens, education happens. People live, work, and recreate, go about everything. So a city is a place and its people. So if solving for a city is like solving for a country or for a state. Except that in India, while the Minister for Water, the Minister for Health, the Minister for Transport, etc. reports to the Prime Minister. At the state level, the Minister for Water, Minister for Health, Minister for Transport, etc. reports to the Chief Minister. But in the case of a city, you don't have that. There's no single point of executive or political accountability. A city is viewed as an aggregation of service delivery sectors. So we will have to fix the city holistically. And that is where I think we have a golden opportunity and imperative with decentralization. What decentralization does is gives us empowered mayors and councils, and further decentralizes governance to the neighborhood level, at a ward level or an area sub level, by taking governance to the people, by incorporating voice and agency of people in governance. It's both an opportunity and an imperative. It's an opportunity because I am viewing this workshop as the beginning of a journey where decentralization may be able to work for health outcomes, and the push for better governance of healthcare can lead to better governance of cities. So this could be a symbiotic and mutually advantageous relationship between public health and cities. And we've spoken multiple times between yesterday and today of how local governance itself finds its roots in public health as an important priority. And the overhang of COVID
provides us that context, further supplemented by unprecedented amounts of money coming through 15th Finance Commission to cities. In Bihar, during the study, we saw how much was the allocation under the National Urban Health Mission component of NHM coming to cities in Bihar and 15th FC. The 15th FC allocation is 60% higher. They don't have any absorptive capacities, which is why only 41 PHCs have gotten built under NUHM, and they're actually struggling to build the absorptive capacities to take the money. To get into the details, the urban department first got excited and transferred the money to the ULB, now has formally written to the health department saying we don't think we can manage it. They are not able to return the funds, and they're requesting the health department to manage it for them. So in many states, this will be the case, where the allocation under 15th FC would have exceeded the absorptive capacity of the local governments. So we are in an interesting phase where we can use this window of opportunity to drive change. I don't fully agree with the narrative on centralization, because I think it actually applies to larger cities more than it does to medium-sized cities and towns. Even in states, irrespective of the political parties, we are seeing a greater willingness to decentralize and devolve powers and functions in smaller cities and towns, where the political economy of land and the benefits of rent seeking are not high enough to act as inhibitors or deterrents for decentralization and devolution. Similarly, in states like Uttar Pradesh, Madhya Pradesh, Chhattisgarh, etc., Jharkhand, etc., many of the states actually started thinking about urban post-JNNURM. So they started actually adopting the model municipal law, which inherently had greater provisions for greater empowerment of councils. Some of those states have actually vacillated between directly elected mayors to indirectly elected mayors, etc. But in many of those states, more than the larger cities, there are mayors with 5-year terms, even if they are indirectly elected. Whereas you take many of the major cities in India, Bombay does not have a 5-year mayor, Bangalore does not have a 5-year mayor, Delhi does not have a 5-year mayor. Whereas many of the smaller cities and towns have 5-year mayors. And we have actually seen in states like Madhya Pradesh, the mayors and councils are politically empowered. They are senior politicians within those political parties. If you recollect, few years back, even in the BJP government in Uttar Pradesh, the deputy chief minister was a former mayor of Lucknow. So these exceptions exist. So the entry point for this conversation may not be through the larger cities, maybe to fly under the radar and work with medium-sized cities and towns and smaller cities and towns. Because the story of urban in India is dominated by the larger cities and towns. Right? So I think the larger cities and towns, that brings me to my last point, which is that there is no one-size-fits-all even in urban. India has 8 cities with a population of more than 4 million. Those problems are global in dimension, and their potential is also global in nature. You have another 38 odd cities with a population of between 1 and 4 million. Those cities have potential, but their capabilities currently don't match up to the potential. You have then another 400 odd cities which have a population of greater than 1 lakh, between 1 lakh and 1 million. And then you have 4,300 cities which are less than 1 lakh. So there is a distinct pattern of urbanization in India, but which comes with spatial contiguities, as I mentioned yesterday. So building of capacities need not happen ULB by ULB by ULB. Building of capacities can happen in a cluster basis, in a shared basis. But decentralization of functions, powers, etc. can happen ULB by ULB. And we are already witnessing that. See, this narrative of saying, which the secretary also mentioned yesterday, that BMC is highly empowered, etc. Many of us will know who the commissioner of BMC is, but you'll never know the mayor of the BMC. What is decentralization if you don't have an empowered mayor and council? That is bureaucratic decentralization. And in Mumbai, are you serious to say that BMC is an empowered local body? When you have an MMRDA, when you have a suburban rail, when the entire geography and economy of Mumbai, a very small role is actually played by BMC. So I think I see a lot of hope, and I see actually a lot of opportunities. I think urban is gaining salience politically. Chief ministers, now many of the chief ministers are urban born and raised. They're not like before. They're urban politicians. Stalin in Tamil Nadu is an urban politician. KTR in Telangana is an urban politician. Stalin is an ex-mayor, yeah. Many of them, Devendra Fadnavis was an ex-mayor. So many of them are urban politicians. Urban politics is getting hotly contested. They're realizing that they don't have an answer to the problem. So I actually see a lot of hope with respect to urban decentralization. It will take different forms and shapes. It won't be a linear pathway. It will be a systems pathway
where context will be queen and content will only be king. So theoretical discourses may not exactly figure out, play out exactly the way we believe decentralization may need to happen. They'll happen based on local context. But we have a window of opportunity with the 15th Finance Commission that gives us the ability to influence the 16th Finance Commission. And as Mr. Vijayanand said, go through the state finance commissions as well. I do see a combination of medium-sized cities and towns and the window of opportunity where there are more politicians fighting more hotly contested urban elections and the opportunity to use finance as a lever, even within public health. So I think if we work together, if the public health and urban sectors work together, there is a fair bit of substantive change that we can usher in. Thank you.
Thank you. Before I invite the CEO of HSTP for the final word, I just want to add a point that we should now start preparing. I think HSTP can take a lead, a memorandum for the 16th Finance Commission on health grants, because 15th Finance Commission, I think it's an afterthought. I didn't have, they have any discussion. Had they known, they would not have given this. But now 16th, we can prepare with empirical data. I request Rajiv to give the final word.
Thank you, Mr. Vijayanand. The problem in having your ex-boss as your chair is that before he tells you to say the final word, he'll tell you what your final word should be. So he has already told me what to say. Now, one of the things that I'd hoped to do, okay, Rini, I won't ask you how much time I have. I'm scared of your answer. So one of the things I thought I would do, rather than summarizing the rich discussion that we had over the last 2 days, was actually respond to some of the comments that came up here. But the comments have been so rich and varied that even if Rini gives me that time, I'm not going to be able to do justice to them. So one of the things what I'll try to do is to pick up a couple, because the other thing that happens that when you go to a workshop, you're asked for your remarks and nobody even notices it, you feel extremely let down. So I've been on that side, and I would like at least to satisfy some of you that some of your points have been taken. Remember, in all the literature, when you look at decentralization, there is always a central versus the periphery. The problem here is that here the center is the state and the peripheries are the local government. While on the one hand, states protest that center is not giving them powers, they're treating local bodies the way the center treats local governments. Which is, what does it tell you? That's the nature of power. That's one. Two, having looked at decentralization at different places, no decentralization can happen without the consent of the central authority. Where it is, see, Brazil under Lula, they had a huge decentralization. We were singing about them in Kerala. Then Bolsonaro comes, the whole thing is centralized. Now Lula is coming back, decentralization might go back again. Same thing happened in Mexico. Everywhere, the decentralization happens at the mercy of the central authority. It can't be helped. That's the nature of decentralization. Second, he who pays the piper calls the tune. Now, if you're dependent on union government for the money, then you'll have to follow the guidelines issued by the government. Otherwise, they choke the money, which is what I've just finished my paper on fiscal federalism in health sector. So this is an area that we've been looking at. When states protest that it is not decentralized, I'm tempted to quote from Hamlet, methinks the lady protests too much. Now, remember, under the Constitution, health is a state subject. 80%, while people sitting in the Nirman Bhavan might believe that they are giving you the money, 80% of the health budget of this country is spent by states, including the small areas like Bihar. Secondly, you're not dependent on an NHM or a central government grant, even for there also the discretion of the union government is very little, because the guidelines being what it is, there is very little discretion that is available to the union government also, because as we who have worked in government of India know, once your cabinet note says something, nobody can deviate from it. So the discretion that is available for the union government is very, very little. So when states protest that they are not getting powers, I think they should look at themselves. If states my thesis is that states do not want to assume responsibility, and they want to pass that responsibility to the union government. If states assume responsibility, as Tamil Nadu and Kerala have shown, you can do what you want. Question is, do you know what you want? So please don't protest against centralization. First of all, look at yourself and see what happens. Same thing applies to the local governments. Before you protest that you're not getting what you want, please ask yourself, do you know what you want? So building that capacity from within, and again, if the powers are decentralized to you, in Kerala we talk about decentralization. It's been decentralization to the local bodies, not to the people. So whoever gets power chokes it at that point. The question is that can we create the structure by which we can draw that money down? The other important point that has come up is the decentralization of information. We collect information from everybody, but we never share that back to them. In fact, it goes all the way to the state government or to Delhi. Sadly, nobody looks at it. Two, it never goes back. So can we be open about the information, because information is empowering. The village councils are interesting, and we are quite keen. We are looking keenly at what Meghalaya is trying to do with the village councils in involving them in health. The migrants' health is something where post-COVID we thought there will be a lot of interest. In fact, we had built grand designs on how to provide universal health. At this health insurance for migrants. Sorry, Tarun, there is no appetite. I can't find, I thought post-COVID there'll be a lot of interest. Nobody gives a damn, and we can't find, even migrants are not interested in getting involved. So I'm sorry to say that is something that we tried and failed. And again, the question that was raised, when you ask a central authority to give guidelines on decentralization, what do you think is going to happen? Whose interests will get protected? So be very careful when you ask for Dr. Vajasav, I agree what you're saying, but please be very, very careful. Decide what you want before you ask for guidelines. Otherwise, people like us are very competent. As we saw in the Finance Commission, the Finance Commission gave a beautiful thing saying all decentralize the local bodies. But the bureaucrats who were there slipped in a small provision, which was the guidelines issued by the Ministry of Health. And then we ensured that no decentralization happens. So be very careful of people like us who draft guidelines. We are experts in ensuring that our agenda gets filled. That's what we've been trained on. Very important point is about private sector. We have no idea of how to engage them, but they will have to be a major player. And one of the things that we may need to look at is that, I think Mohan has left, a study we carried out in Mysuru showed that even in the slum population, they don't trust government hospitals. They prefer a private provider. Now, why don't you accept that fact and see how government money can be used to purchase services from private sector if that is what your population wants. As I mentioned about funds, what is the level at which your power comes from the money that you control? What is the level of tax effort that local governments are willing to fulfill? How much of your tax revenue has actually been collected? Even in Kerala, it's a huge amount of that needs to be that remains to be collected. So you don't want to become unpopular, and you want the state government to give you the money. The state government doesn't want to get unpopular, so you want more of the GST money coming in without making use of your tax resources. Decentralization also means assuming fiscal responsibility for resource mobilization, not only for spending. I think these there are lots of issues on my table, but fortunately Lynn is not looking at me anyway. Okay, but even then, no, I'm sure she'll start looking at me, so I won't carry on much. Lynn, can I conclude? What do I? No, I'll give you the last word. Don't worry. Don't worry. Oh God. Now my paper. Oh God. I had written down the list of people to thank for this, and given this thing, I've forgotten. No, it's still here. This conference has been a great learning experience for us. I mean, I mean, it's also been a nightmare actually. You know, we were trying to get three organizations to work together, and my team has been. I don't know. I think Pallavi, you should get your BP checked immediately after this. It's been such a nightmare, you know, getting people from from say Bellary or from Hubli, and then and all sorts of different parts of India, and getting you here, sir. But I'm happy that we did that exercise because this meeting has become enriched because of your contribution. A couple of bureaucrats or academics sitting here and talking here would have been nonsense. It has been enriched by your participation. So I'd like to thank all the elected representatives who have attended this conference. You have really made a difference to this whole workshop. I'd also like to thank our co-collaborators, the Health Action by People and Janagraha for this collaboration. HAP, of course, was our partner right from the study, and not only the HAP officials, but also the innumerable number of researchers, the number of respondents who volunteered that time during the COVID time. Given the bad connectivity over there, they spent hours talking to our people. I'd like to thank our researchers and all the people who responded to the great work that we did. In particular, I better not name people, but I think I'll still have to name Dr. Vijaykumar and Dr. Ramankutty. Dr. Vijaykumar has been under the radar, but to a large extent, this whole exercise is a credit to their organization skills. The way we brought in the way we collaborated with Janagraha was that we didn't know they existed. No, that's not true. Srikanth invited me for a consultation anyway. But when we started, when I was associated with all the papers that was being prepared as part of the HAP study, when we looked at it, what we found was the urban area was extremely weak, and that was coming through very clearly. And I suggested that let us do another study looking at the urban areas. We even started looking around for people who could do it. I was talking to Rajini and at BMGF. Rajini said, "Why are you doing it? No, we are anyway funded a study by Janagraha. Why don't you talk to them?" And then we spoke to Janagraha and said, "So can we have a Jugalbandi, of the rural being done by, the part of the rural being done by HAP and part by you?" And thank you, Janagraha, for joining us and being part of the study and putting up with the innumerable requests, running around here and there, and then it's been great working with you. Thank you. And thank you, Anakha, for capturing this of the 2 days. If you noticed, Anakha is known for capturing things and saying things that may not actually have been said, but should have been said. So this is a tremendous skill that Anakha has. It is said about in one of Shakespeare's texts that Dr. Johnson corrected, that another person said, if this is not what Shakespeare said, this is what he should have said. So same thing applies to Anakha. Thank you, Anakha, for this work. My colleagues at HSTP, I don't know whether I should apologize to them or should thank them. It's been a nerve-wracking session for us. We had 3 teams: the health system governance group led by Pallavi and Sakshi. They were the people who were in charge of the content, and the finance and administration led by Sridhar, Peter, and Divakar were the people who did it. We must have dealt with Peter and Pallavi. You can also imagine if that was an effort that was needed from your side, what effort would have been required from their side to coordinate it. Thank you very much. And Rahul and Alia handled the other logistics part. Thank you to my team for having done this. And our gratitude to the event management company for the leading edge from Mumbai who had done this, and to the Ashoka Hotel and their staff. And the final word of thanks has to go to a person who's joined us a few days ago, but has become our close associate, and I'm sure has become your close associate also, which is Ms. Rini Simon Khanna, who for the excellent way in which she has kind of guided us and has managed a session. And to a large extent, this has come out because of this is we've been able to handle it to the great effort that and the great experience that she has. Finally, to the participants, I mean, we actually were not prepared for the number of people who came. Let me confess that now. We actually had to order additional food because we are not expected that so many people land up. Thank you very much for joining us today, especially the HSRC team. We had a large number from their side and all the others who joined from other institutions. And to all of you who have come here today, thank you very much. And we will share the presentations, except Tarun's. Tarun, do you reconsider your thing? Can we share your presentation? Oh, Tarun is also good. So Tarun's presentation also will be there. So we'll share all the presentations, and Anaka's, wonderful in advance a summary that she'll produce. We'll give that to you, and we will be. I'm not sure. I'll be able to inform each of you on what we'll be able to do. But given the fact that my boss, it's not my former boss, he's my boss even now, has asked us to do, we will be taking this forward. Once again, thank you very much.
May I be allowed to?
You have the last word.
Well, we've had a lot of discussion, a lot of dialogue, a lot of analysis, creative goal settings. We've got problem solving, basically a lot of blah, blah, blah. I hope that we can take these conversations forward and beyond this workshop and translate them into action, as the boss of all bosses, Mr. Vijayanand, said, that it needs to be translated into action on the ground. So in the end, I think I have to only say a big thank you to this wonderful audience that has been listening to me and helping us make this entire workshop run on time. Thank you so much for cooperating with us. More power to those who are working in this domain. For now, I think the only thing we can offer you is a cup of coffee or a cup of tea and a few cookies. So please join us now. Thank you.